So let's begin. Good morning, ladies and gentlemen. Yes, it's quite loud. First of all, let me thank you all for coming here on a Saturday morning. This is the fourth seminar, which is titled Dr. Victor Ochoa, who is not here with us today, but he's always here on our minds, as if to say. We always remember him fondly, so that's why we have dedicated the name of the seminar to the doctor. I don't have much to say, actually. I'd just like to thank all of you for coming, and of course the organizers. Vicen has been preparing this seminar for 2 years now, and he has, if you have taken part in the organization of any scientific seminar, you know how hard it is to dedicate all your time and effort to that. So that's all. We have a beautiful day out there. So let's stay here until 2 p.m. or maybe a little bit earlier. And I'll give the floor to Mrs. Poveda, who is the manager of the Bioscience Research Institute. Thank you, José Ignacio. Good morning, ladies and gentlemen. Actually, it's a great pleasure to be here today, this morning, in the conference hall of Álvaro Cunqueiro Hospital, introducing the fourth seminar, Victor Ruiz Ochoa, on epidemiology in inflammatory bowel disease. And I'd like to welcome all of the speakers and, of course, all of the attendees who are here physically, but also all those who are following us via streaming. They have told me there are quite many people following us online. And I'd like to give my special thanks to Dr. Aline Sharbati and Dr. Naila Arabi, who have traveled from far away to be here today. So special thanks to both of them for coming here.
Your time in Vigo. Nuestro instituto de...
Our research institute, Galicia Sur, has recently received last summer an award by the Carlos III Health Research Institute, which means that we are located at the top of biomedical research nationally, and it means a lot to us researchers, and it really ratifies the excellence of the research carried out in this center. And that's basically because we've got the best experts and the best professionals in their fields of research. So it's quite a pleasure to have some of them with us today, experts in inflammatory bowel disease and similar pathologies, and who are actively participating in research, studies, and essays which are providing top quality scientific results and research about IBD. It's also a great luxury to be able to listen to them and to be able to participate with them in this kind of seminar, which is a meeting point where we can all exchange our experiences and our knowledge among the top experts in the field, domestically and also from other countries. And in particular, it's very important for our research institution to be the host of the seminar. So that is why I would like to acknowledge the great job carried out by the Digestive Pathology Research Unit, particularly Dr. Hernandez, and also the head of the digestive ward, Dr. Ignacio Rodriguez. Also, thank you very much for organizing the whole seminar, because we all know how hard it was for all of you to be involved in the organization. In the current context, with the purpose of generating scientific research and clinical research, we need to highlight that all of this is actually allowing us to get some positive results for society and for patients with IBD, because all of the results generated as a result of the studies will help to improve the diagnosis, the treatments and the clinical follow-up of people living with IBD and similar pathologies. And moreover, I would like to also highlight and I would like to acknowledge the importance of translational clinical research, because obviously it's a good indicator of quality in the patient care that we provide. I don't want to talk much longer because we have a very intensive day of work ahead of us, so I do hope you will enjoy it and you will benefit from the results. I hope that new research lines will arise from this seminar, perhaps, and we can keep on making progress together in order to understand better the IBD. And once again, welcome to all of you. Thank you very much. Eva, I'll give the floor now to Dr. Vicente Hernandez, the alma mater of the meeting. Thank you all for attending the seminar, and thank you all to those who are following via streaming. It's the first time actually that we organize a seminar with streaming, so with the purpose of allowing everybody to follow it. And well, let me just summarize why this seminar is not an isolated event. I mean to say that it is not, you know, something that will have no continuation. This is actually the fourth of its kind. It's the fourth seminar that follows up on a series of topics of epidemiology, which began in 2015. Back then, we discussed the contributions of research to clinical practice, why there was an increase in the incidence of the disease. The following year, we spoke about the characteristics of inflammatory bowel disease. We talked about risk factors, and the following year we talked about the course of the disease and events related to the disease, extra-intestinal manifestations, cancer, psychological factors, just the impact of IBD on the quality of life of patients. And in the last seminar, in today's seminar, we wanted to cover different age groups, such as women, men, ethnic minorities, the elderly, children, so as to complete the circle. So we have already discussed in previous seminars the clinical approach, and today we would like to hold a discussion around the main challenges that we face in the future and what we can discover in the different epidemiological studies that we have been covering. So this is like the end of the cycle, and next year we will begin a new cycle. We have listened to so many great epidemiologists, the top leaders of multicentric studies across the world, top experts in clinical research. They have exchanged their viewpoints on IBD, and today we have more or less the same goal, to hold a panel discussion about the epidemiology of inflammatory bowel disease. Thank you very much for coming. So let's get started. First of all, let me introduce Mercedes Busto, who is from Pontevedra. He's a pediatrician from the pediatric unit of the Pontevedra Hospital. And she's going to, well, she's actually taking care of pediatric IBD patients together with the whole unit from Pontevedra, such as Dr. Daniel Carpio, and they're also in charge of the transition unit. Thank you very much, Mercedes.
Ah, sí, perdón. Bueno, gracias a todos por estar aquí y en especial a los organizadores.
To all of you, and thanks also to the organizers for inviting me in order to give you a global approach about IBD in pediatric patients. I'm not an expert in epidemiology. I'm a clinician myself, So it's very interesting to be part of this world. When Vicente invited me to talk, I thought, how could I speak for 20 minutes? And now, after having researched the topic, I'm thinking, is it just 20 minutes that I have to talk about all of that? So I just want to give you a global overview of what I learned preparing my presentation. The first topic to be discussed, which is very important in order to understand the talk, is that approximately 25% of patients with IBD have an early onset during childhood or adolescence, younger than 18. The epidemiology will help us understand possible etiology, the causes of the incidence rates. It will help us understand the disease better and control it better. But it also poses many difficulties. For instance, defining the case, the so-called insidious clinical presentation. You know that classification has changed through time, so it's not easy to compare the different studies because there are presentations which are classified in a particular way, and in the past they were defined in a different way. At the same time, what is pediatric IBD? For some it is below 16, for others it's below 21 years of age, and in Spain, you know that the pediatric units take care of patients until 15, so we would consider it until 15. At the same time, there has been an increase in the incidence rate, and it seems that children are a little behind in the diagnosis compared to the adult population because it's hard for children to undergo invasive tests. So most of the studies in pediatric age are very heterogeneous. Many of them are prospective studies, and that makes it difficult to compare and contrast data. So the global epidemiology in IBD among children remains a challenge. I'm going to first give you an international overview with a couple of systematic reviews which have been made, one in Europe, and later on we will focus on particular studies. This is a map showing a systematic review looking for studies among the young population, meaning people under 21. And the first thing that draws our attention is the gaps. I mean, the lack of data in most countries. And in those countries where we do have some data, the usual one is the countries with the highest incidence rate, which are the dark blue, are located in the north, such as USA, Canada, and Scandinavian countries in Europe. The interesting part of this systematic review is that it shows that practically in every country, incidence rates are on the increase, and prevalence is also increasing in 100% of countries. The maps about chronic colitis are also coincident with regard to IBD in the pediatric population. The regions which used to have the highest incidence remain with the highest incidence and prevalence, and there's also a surge in countries where it was not present before. There is a clear trend on the increase in northern hemisphere countries, and we need to keep on intensifying diagnosis in children because it is diagnosed much later in children than in adults. At the same time, in some age groups, we can see that incidence increases more in bigger children, whereas in other groups, incidence seems to increase more in younger children, so there is no consistency. So the global trend is an increase across every age group, although in some areas, such as the UK and Canada, it seems to have reached some stability. So we can see that there are increases in any of the different types of IBD in the pediatric population. There is some stabilization in some studies in smaller children, but there is an increase in the UK. And in Canada, for instance, there was an increase in younger children and stability in older children. So that is why I have said there is inconsistency with regard to the age groups. With regard to the Crohn's disease, there is an incidence which is higher than colitis. This ratio is even bigger in areas such as Quebec, which is 9:1. And in other countries, we can see that colitis is more frequent, such as Italy, Poland, Finland, and some areas in Northern California. So what is going on in Europe? Well, we can see this systematic review, which is a 50-year systematic review of studies. We can see that the studies are methodologically not very sound, except for the EPICON review. We can see the same north-south gradient. The incidence of Crohn and colitis has increased across Europe in the last 50 years, with the highest incidence in Scandinavia, with 9 to 10 per 1,000 inhabitants per year, with a very high prevalence for Crohn's disease and ulcerative colitis. Globally speaking, the incidence rate is higher among adolescents compared to younger children, as was the case also in Canada. With regard to disease subtype, we can see that Crohn's disease is more frequent in northern countries such as Scotland, Denmark, Scandinavia, Finland, Sweden. The dots correspond to regional studies which do not show what is going on across a whole country, and those which are painted blue have national studies. In ulcerative colitis, the data corresponds quite similarly to Crohn, and we can see that the highest incidence is found in Slovenia. We can see that for ulcerative colitis, it would be around the first quintile. This is the trend of incidence for Crohn on the right side and colitis on the left side between the 1980s and 2015. You can see at the top the studies corresponding to Northern Europe, and in the bottom part we can see studies corresponding to the South. There are very few studies in the South, most of them done in Spain and Italy, very few in the east of Europe, most of them in the Czech Republic, but we can see that the incidence of Crohn's disease is on the increase. Maybe ulcerative colitis has reached a greater stability in the north, although in Sweden and Ireland there has been an increase according to the studies. So we can see an increase in incidence in both types of IBDs, Crohn's and UC in northern countries, and I'm going to refer more specifically to Spain. This is the situation in Spain according to the SPIRIT study, which ranges from until 2009. And there were two previous studies which were regional from the north of Spain before the 1990s, with an incidence of Crohn's and colitis which was rather low in Navarra, and that the study was carried out between 2001 and 2003, which shows an increase in the incidence of both Crohn's and UC. But let's look at the SPIRIT study in particular. This is a retrospective study, multicentric one, with the purpose of bringing together all of the centers taking care of pediatric IBD patients in Spain. And it has taken data from pediatric units and also some adult units. You can see actually data from some of your wards of those present in the hospital. It was very useful to receive the data from all of you, because as said earlier, in Spain, pediatric age is considered to be until 15, but the study considers children up to 18 years of age. So we need to take into account data from the adult wards. So the cohort is 2,000 patients. Crohn's disease was present in 55%, 37% ulcerative colitis, and undetermined colitis, 17%. Most of them were Caucasian, and there is a continuous increase both for Crohn's disease and for ulcerative colitis. The incidence in 2001 was 1.95 per 100,000 inhabitants a year, which is similar to the data reported for adults, which shows that 25–35% of IBD patients have an early onset during childhood. However, the incidence in Spain is clearly lower than in other Northern European countries and USA. With regard to the global incidence, in 1996, the data from the start of the SPIRIT study, the incidence was 0.97 per 100,000 inhabitants, and it increased to 2.8. You can see the purple corresponds to Crohn's, and the green line corresponds to UC. With regard to the geographical distribution, we can see the same north-south gradient. It's more prevalent in the north. And with regard to the gender distribution, IBD is more frequent in boys, 56.4, and 43.64 girls. There is a higher male predominance for Crohn's disease, which correlates with global data, but there is no gender difference for ulcerative colitis and undetermined colitis. This study is a systematic review between 2010 and 2016. I cannot read many of the figures because I know there is another topic related to the gender differences in IBD, but I'd just like to draw your attention to the green chart, which is the pediatric range from 0 to 18 years of age. This would be for Crohn's, this would be for UC. With regard to Crohn's disease, this is the female-male ratio, which means that if you are below the line, it's lower for females, and if you are higher, it's higher for females. So it seems that the risk is lower, 30% lower for females between 10 and 14 years of age. For ulcerative colitis, the trend is quite the opposite. It's slightly more frequent in females, particularly between 5 and 9 years of age, and girls have 22% higher risk of ulcerative colitis. With regard to the presentation forms, we're going to focus on the EuroKids study, which is a prospective study of European countries plus Israel between 2004 and 2009. Out of the 1,000 patients, 34% had ulcerative colitis, and extensive colitis and pancolitis are the most frequent presentations in children, which would correspond to the gray and white lines or bars. In children younger than 5, there is practically no proctitis. Proctitis usually appears in 5% of cases and often after the age of 13. Atypical presentations are not very frequent, but we need to pay close attention to them in order to make a correct classification of the disease. So 2% presented with cecal parchment, 5% preservation of the rectum, 10% IVs because of reflux, higher in males than females. With regard to Crohn's disease, out of the 2,000 patients, 59% had Crohn's disease, and there is also a significant impact on the colon. In children, there is a greater impact in the colon, also in Crohn's disease. The ileocolonic presentation is in 53% of cases, isolated colon in 27% of cases, and this is frequent in children younger than 5. And with the terminal IDM presentation, this is in a percentage of 16%, and usually among adolescents. The most common manifestation is inflammation in 82% of cases, and only 12% had stenosis and 5% penetrative inflammation. The median age was 12.5 for Crohn, and the percentage was lower for undetermined colitis. Both for UC and for undetermined colitis, they are predominant in the first 5 years of age, while Crohn's disease is predominant after 6 years of age. Between 6 and 16, Crohn's disease is more prevalent, and before 6, ulcerative colitis and undetermined colitis are more prevalent. IBD, as we know, affects the colon in 83% of children under 5, according to the Montreal classification. The SPIRIT study, did not use the Paris classification, and for that reason there are some differences with modern studies. But if we put together L1 with L3, the ileocolonic presentation, the figures would be similar. The ileocolonic presentation is found in 56.9% of children, and in UC, the most frequent manifestation is pancolitis and extensive colitis. With regard to extraintestinal manifestations, we can see that almost 30% of children have extraintestinal manifestations, and during the course of the disease, they are more and more frequent. They are related to the severity of the diagnosis, such as arthritis, joint manifestations, skin manifestations, but also delayed growth. Delayed growth is an obvious extraintestinal manifestation, which is very clear in adults, but it is also very, very important for the pediatric population. It is present between 10 to 56% of pediatric IBD patients, and sometimes even up to 10% of IBD pediatric patients have that single symptom, the low stature. In natural history, we need to bear in mind that children have many decades of disease course ahead of them, so we need to take care of that when we consider treatment and diagnosis and assessment of the patient. After 5 years, children with an early onset of ABD have a 24 to 43% of stenosis, fistulae in 14 to 27% of cases, and perianal disease between 25 and 30% of cases. The risk of surgery is 7.9% after 1 year, 25.5% after 5 years, and there is a lower risk of intestinal resection in children younger than 10 years of age. There is also a high risk of colectomy, 6.7 in UC after 1 year, and higher than 20% at 10 years of age. Before the new therapies arrived, mortality was higher than in the overall population. 32% went into remission, but 54% of patients retained their symptoms, and they were corticoid dependent. After the biological drugs, the remission rates are much better, and the prognosis has also changed in the last 3 decades. It has improved. There is a frequent impact on the growth rate, which means that up to 30% of patients will not reach the target height, regardless of the treatment that you give them. This is important to be considered for the children's health. We know that stature is a good reflection of overall health, but it's also important for the psychosocial environment of the child. Cancer is rarely found in children, even though they present with IBD in the pediatric age. Probably we will never come across, thankfully, with colorectal cancer. This is very rare in the pediatric age. But it's also true that if they have an early onset with IBD, there is an increased risk of cancer. For instance, there is a 3.7% higher risk of cancer after 17 years. And also the risk of colorectal cancer is higher if they have an early onset of IBD compared to those who have a later onset in adulthood. At the same time, the improvements in treatment with the new biodrugs, there is a lower risk of malignity. And in recent studies, we have found no differences in mortality between the pediatric IBD patients and the adult IBD population. We can see that the evolution has changed a lot in recent decades. So let's talk about risk factors and the differences between adults and children, just to finish the presentation. Risk factors. Most of them have to do with factors which have an impact on the microbiota, that is, changes in the microbiota. However, the influence has not been proven. Probably the taking of antibiotics in early ages is related to Crohn's disease, particularly in very early stages of life. In the Scandinavian countries, they have thought that perhaps antibiotic therapy was related to the early onset of IBD, but well, this is probably not correct, because it is proven that in Spain, children receive many more antibiotics than in Scandinavia, and however, IBD is lower in Spain than in Scandinavia. We know that nursing can be a protective factor for children. At the same time, nursing is protective, at least for an early onset of IBD, but obviously it's not so important as the child grows older. Having a more hygienic environment is associated to a higher risk of the disease. Pollution and contaminants in the air is also associated to IBD in the younger population. Smoking is very low in children, therefore is not such an important factor. But what about passive smoking at birth? There is an increase in the incidence of IBD, but it's not as clear as the risk for smoking adult. The Western diet also increases the incidence for Crohn's disease because of the high intake of animal fats and simple sugar, and a decrease in the consumption of vegetables and omega-3. There are also some genetic mutations in NOD2 which pose a higher risk of surgery. The early use of anti-TNF decreases penetrative disease up to 3 times, but it has no impact on strictures or surgery. And there is also factors for worse prognosis, such as later diagnosis, seropositivity, etc. And the relationships between IBD in children and adults, we can say that Crohn's disease is more frequent in males than females. The most frequent type is inflammatory presentation in 80 to 90% of cases. There are higher rates of undetermined colitis, especially in younger children, and also many of them have non-classical syndromes. Sometimes only low stature or children that will not eat, and that would be the only symptom. Also, delay in puberty, which cause a delay in the diagnosis. There is a Spanish study which points towards the fact that usually Crohn's disease has a delay of 5 months until it is diagnosed. In children, ulcerative colitis presents with pancolitis or extensive colitis, which compares to 50% in the adult population. The ileocolonic presentation is the most frequent. There is a very high affectation, and there is also a very high impact on large segments of the small intestine. At the same time, this is explained because of the later diagnosis, but it's also true that children respond much better to treatment. There are also differences in treatment, such as exclusive or partial enteral nutrition, which is very useful for treating flares, and that helps us to reduce corticoid use. But there is also a lack of pediatric clinical assays because we tend to extrapolate the data from the adult assays, and this is not always correct for the pediatric population. The surgery rates are lower in children than in adults for Crohn's disease, however, not for ulcerative colitis. The cost of care is much higher because of the prolonged treatment. And the fact that you are diagnosed with a chronic disease in childhood is a very significant problem because it correlates with the social stigma and also with a poor quality of life. So this will have an impact on the child's social interaction, on their concentration, and on the familiar dynamics. So we need to improve knowledge on pediatric IBD. We need to also explore the differences between the children and the adult population. We need to understand better why it is increasing more in younger children. And we also need more populational studies, and we also need to look for predictors of complication in the disease so as to provide a more targeted treatment depending on whether the person has a risk of have complications in the near future. We're still very far away from being able to prevent IBD, but we are on the right way. Thank you.
No sé si hay alguna pregunta después.
Muchas gracias, Mercedes.
Thank you very much, Mercedes. We're going to leave all questions for the end of the full presentation. So I'm now going to introduce the next speaker, Diego Casas. He's from Zaragoza. He works at the hospital there. If I can't remember his name, Miguel Servet, right? Sorry, I had forgotten the name of his hospital. Well, he has a grant there in Rio Ortega. Apart from being a doctor at the hospital, he has a grant for Rio Ortega, so he can exclusively be devoted to carry out research on IBD. He's conducted many studies at national level as a member of the IBD unit in the Miguel Servet, and he's the first author of a study assessing the effect of biological drugs in patients suffering this disease at an elderly age. So that's him. Whenever you want to, the floor is yours. Good morning, everybody. First of all, I'd like to thank Vicente for inviting me to be here and give this speech, also the rest of the organizers and the audience as well for being here. So, we're going to move from one end to the other in terms of population. From children, we're not going to focus on the elderly. These are my disclaimers. And well, item number one, why are we interested in this population? Why do we want to talk about the elderly? Well, first of all, because this is a group of potential patients that is already very important, and it's going to be even more. To the left, you see the European populational pyramid today, and the estimate by the UN for 2050 to the right, where we can see that the area of interest for this talk is going to keep on increasing. If we go to population percentage, we see to the left above 65 years of age, that's the point, that's the forecast, and to the right above 80, that's the point we're at now, about 8% of the population, and the perspective, the forecast is that this will double from now until 2050, more or less. So this is going to be a group of patients with playing a huge role in terms of from a clinical viewpoint. This is a study conducted in Minnesota, combining these studies, increase in population. Purple and blue groups represent patients above 65 and above 80. And you see the projection for the future. There's an increase already. And you see the data also for IBD. And we can see here that particularly for patients suffering from Crohn's disease, the group was also increasing. Perhaps this is a more relevant than popular group when publications are concerned. If we, for example, go to this data, if we look for patients with inflammatory bowel disease and, well, with this data, elderly, we obtain these results. If we make a search in childhood, 115, with pregnant women, 172, and if we compare this with the biggest group today, only looking for COVID, that's for the last 2 years only, we see that this doubles the results when it comes to the elderly. So important, but perhaps not as well known as it should be so far. When we talk about elderly patients with IBD, we have to make a difference between two main groups. On the one hand, we have those patients with IBD diagnosed when they were already old, and another group of patients who had been diagnosed previously, and they will come to a point when they are elderly patients. As for patients diagnosed when elders already, well, we had the classical modality of incidence difference that some current studies have sort of disassembled or sort of brought into pieces. We'll later on give more details about this, but we have here some data about incidences today, 5 to 11% of incident cases, according to Epidemiología in France. On the other hand, patients are about 10 to 30% of the IBD patients that are already taken care of. And if we look at different age groups, talking about the elderly, 65% would be 60 to 70 years old, 70, 25% 70 to 80, and 10% would be above 80. Let's now turn to some epidemiological data. First of all, from the EPI IBD cohort, I'd like to thank Vicente, by the way, for sharing this data with me. And if you look at this, you see by age groups, that bimodal theory that seems to be not so up to date today, well, it seems that that loss of myth is continuing. We see incidence of colitis and Crohn's disease here. It progressively decreases. And if we look to the side of the slide, we see relative incidence for each of the IBD groups. We see an increase quite significant here at this level in terms of percentage of patients suffering from ulcerative colitis when compared to Crohn's disease. Some more studies here. The EPIMAD cohort in France, for example. If we look at the Charpentier study, if we look at the characteristics of these diseases, this was mentioned for pediatric population as well. There are some differences with general population, overall population. Well, it's funny, but there are some coincidences between children and the elderly, which is the prevalence of colic disease compared to other manifestations, particularly in Crohn's disease. Also, a predominance of Crohn's disease in non-complicated manners, the B1 phenotype compared to other kinds of phenotypes. As for ulcerative colitis, there are some doubts. We'll later on enter into more detail in terms of how serious the first diagnostic outbreak is, but the data seem to suggest that here it's different to the pediatric population. Some studies show not such a huge extension of ulcerative colitis when the diagnosis takes place, particularly when compared to pediatric populations. Less than 15% had an extensive UC, compared to about 50% or even higher data, according to what we've seen in pediatric populations. Again, we go back to the EPI IBD cohort for this data, and you see here to the left Crohn's disease locations, where we see a predominance of the colic location, and to the right we see phenotypes where we do not see that prevalence, that predominance, that change in terms of a higher phenotypic prevalence. Over here, you see B1 phenotype, 72% in young patients, 68% in middle age, and 70% in the elderly. So, slight discrepancy with regard to this data here. as for colitis extension, again, the EPI-IBD cohort, a European, by the way, multi-center cohort. I've not described it before, just to give you some details about it. High quality from a methodological viewpoint. And we see the data here. Low extension forms are reduced, so this contradicts previous studies somehow. Why is this so heterogeneous when we analyze results in the disease amongst the elderly? We've talked about children before. Well, in the elderly, there are other factors that can make the diagnosis slightly more difficult when defining an IBD as a case. Why? Well, basically because there are some pathologies that sometimes when we have an elderly patient, we're gonna think about other diseases rather than IBD, typically. When we do a differential diagnosis, we have some factors that we don't have in young patients. Some of them, we may have them, such as NSAID consumption, for example, but some other issues that you see here are more frequent in elderly populations, and that can make our diagnosis more difficult. In fact, when we talk about errors in diagnosis and delay, this is even more exacerbated and difficult with elderly patients. About 60% of elderly patients diagnosed with IBD had been previously diagnosed with the same sort of symptoms, but another pathology that only happened in 15% of young patients. If we think of time, we have 6 years of delay even in diagnosis in some cases. That obviously caused lots of difficulties, delay in terms of treatment onset and so on. So briefly, summarizing everything, there are some differences between elderly and younger patients. Basically, genetics are not so relevant in elderly population compared to young populations. Localization, Crohn's disease, colic location, and so on. And in ulcerative colitis, we frequently have a distal involvement more frequently. So these are the disparities. We also have some similarities. Seriousness, that diagnosis seems to be similar. For example, symptomatology that patients present is more or less similar. It seems that some patients may have not so much diarrhea and abdominal pain. And EIM is also similar when we compare elderly populations and the other subgroups. But in elderly patients, we see some specific conditions which have nothing to do with their disease. They may have the same IBD as a 40-year-old patient, but there are some features, intrinsic characteristics that refer to this group and that mark a difference. For example, they're going to have a higher risk of hospital admission, not because its IBD is going to be more serious, but because they have more problems with nutrition, more anemia, they present more mortality in admission, and so on. They have the same risk of undergoing surgery than a younger patient, but if they end up having to go for surgery, their hospital stay is going to be longer, and complication rate is going to be worse as well. Infection rate is also higher, whether because of pathogens, whatever. And also, they typically have a higher thrombotic event rate. They're also going to be at a higher risk of neoplasia, for example. Risk of neoplasia in elderly patients, well, we know that in IBD we have some neoplasias, particularly colon cancer, but others we have to pay attention to. Well, in the elderly, this is even worse. There's a bigger impact. These are data from the Spanish Medical Oncology Association and its registry. You look at the years, how old those patients are, and you see that from 65, cancer incidence goes up. And this is also affecting patients suffering from IBD. Especially relevant colorectal cancer. We all know we have screening programs and so on in all our patients with colic involvement and so on. But we also have to remember the elderly, they have a higher colonic involvement, so these kind of cancers are going to be more prevalent in these kind of patients. But also frequently when we get late to it. You see the details in the slide. There's a Canadian cohort which says that 30% of the elderly patients diagnosed with a colorectal cancer were diagnosed before the 8 years of follow-up. So we were late. That screening was conducted later than the moment when that patient developed that neoplasia. There's an increase in in terms of risk of other neoplasias that are not so frequent, but that are there as well, apart from those that are intrinsic to therapies that applies to young population as well, but the risk is higher in elderly patients. For example, thiopurine treatment associated risks and so on. So taking all of these characteristics into account and going into more practical details, can we treat patients with IBD similarly to other patients when they are elderly? Well, we have to take into account issues such as, for example, polypharmacy. Outside IBD treatments, without taking into account what we're going to use, very frequently we're going to see a polypharmacy. The average in IBD patients is what you see in the slide, 7 drugs per patient, more or less. Also, if we apply a therapy, a treatment, there are going to be some characteristics for these patients that may have an effect in terms of adherence, use, and so on. There's a higher cognitive deterioration or impairment prevalence, worse adherence if the therapy is complex, if dosage is complex, it's going to be more difficult for them to use that therapy. They may have some difficulties to administer a topical therapy, for example, due to arthrosis, whatever. There's going to be some anal incontinence that is also going to have an impact in terms of topical therapies. And also there's going to be a lower physiological reserve. Well, these are some data about some of our visits conducted during the past few years. And you see here data, for example, active medication 24, 10, 10, and 18. So this is something that's not shown by studies only. It's something that we see in practice, by the way. And this polypharmacy also has an impact in terms of adverse reactions and complications with the drugs we're using. Some of the drugs we don't typically consider in a 40, 50-year-old patient. We're not going to think that's going to give us a problem. Well, it's going to give us, or it may give us a problem in elderly patients. We can have complications with different kinds of drugs, such as, for example, acetylsalicylates. We don't take them into account in other populations. Also here in corticoids, for example, higher risk for osteoporosis, hypertension, hyperglycemia, edema. We have to be more careful. And also, perhaps because of this, the data in terms of how we're treating our patients are different and they change. There are huge differences in terms of the drugs we're going to use with elderly patients and with young patients. And this is where we enter into the discussion. Why do we do this? Because we have a milder situation. They don't need these drugs because we're afraid of using those more powerful drugs. Why? What are the reasons? And well, what are the facts, first of all? The facts are that we don't use these drugs so much. In the EPI-IBD cohort that I referred to before, for example, if we look at elderly patients, they use half of immunosuppressive drugs compared to young patients, and only a small amount had an anti-TNF therapy. In this other cohort, 3% of patients undergoing a biological treatment, and this amount with immunosuppressive drugs. That's what you see in the slide, but the difference is that a huge amount had corticoids as well. And in this last cohort, 18% of patients with anti-TNF compared to 5% of patients above 65 years of age. Again, the question, they didn't need it, it was a milder disease, or they needed it, but we are afraid of using them. For the EPI-IBD cohort, similar data, biological immunosuppressive drugs lower in elderly patients, but if we look at surgery rates, they are not lower. There's in fact a trend towards an increase. And if we look at corticoid use, we see that it's more similar if we compare different groups. So it seems that unavoidable drugs such as corticoids when there's an outbreak or others in surgery are used, but we do not want to use more powerful drugs and those with a higher risk of having some of the secondary effects such as immunomodulators and so on. What is the information we have when making these decisions, when deciding to use one drug or the other? It was said before, there are no studies for pediatric populations. We extrapolate data from adult populations. Well, it's similar for the elderly. If we look at average ages and treatment groups, if we look at the approval clinical trials, well, treatment groups have between 37 and 42 years on average. There's a long way to go until my 80-year-old patient. This is a summary of a paper published in The Lancet. It tells us that a huge amount of clinical trials conducted with biological drugs had a limited age. We see between 70 and 80, it's more frequent. So 60% of the trials did not accept elderly patients to a lower or longer extent, depending on the age we consider as elderly, but they were not accepted. And then, in some cases, we accept age, but we add limitations to comorbidities. So typically, those patients left aside are elderly patients. Perhaps they were okay in terms of age, but because of that comorbidity, they were left aside. So we also need to extrapolate these results from clinical trials to our clinical practice. So what happens in real clinical practice? Let's look at anti-TNFs first. This is where we have more studies, the ones that have been with us for longer, and where we see a greater difference in results when comparing younger and elderly patients. To the left, you see cumulative incidence of discontinuation, below 40, 40 to 60, above 60. As age increases, discontinuation also increases for the drug. Why? There's a higher adverse effect rate, more tumors, more many things. And in fact, our NADA registry data show that infection rates basically doubles that of younger patients, and other rates as well, such as de novo neoplasia and so on. Something we need to take into account as well, experts in the elderly say so, we're always told an elderly patient is not the same as a frail patient. You may be old, but fine. And we have this conversation with many of our colleagues frequently. Yes, he's 70 or 80, but he has a normal life. So it's not the same. And this is what this study wanted to prove. It's not age, but frailty. Based on a machine learning mechanism, they managed to assess the frailty in a cohort. And instead of dividing cohorts between young elderly, they divided this between fit, frail patients. And they saw that, for example, after 1 year, infection rate was a lot bigger for frail than for fit patients when adjusting per age. So probably, there are only data for anti-TNF regarding this, but probably what we have to bear in mind is that it's not only whether the patient is old, but also whether he's fit or not. What else do we have here? As for drugs, well, for vedolizumab, for example, when compared to anti-TNF in elderly patients, what we saw is that at the beginning, in the first few months, there was a trend towards anti-TNF with best best results, but that is equal as time goes by. If you look at here, you see an Italian cohort, Crohn's disease and ulcerative colitis. You see, for colitis, there was more vedolizumab discontinuation in elderly patients compared to young patients. But for Crohn's disease, we saw that it was exactly the same. For ustekinumab, and these are data from our own registry, our own cohort, NADA. Again, drug maintenance, continuation, you see the data, basically the same. Well, some of you may say, well, some of this group, that's not young patients. My boss, for example, said, I'm part of the elderly group. Well, it's not my fault if the cohort sets the limit at 60 years of age. We can discuss whether 65 would be better. 70 different organizations choose one or the other, United Nations, ECHO. Probably the 61, the one by the ECHO, is too low. Perhaps we have to bring it up, but that's what we have so far. As for safety results, in the study we coordinated with ustekinumab, we saw that there was no difference in terms of incidence rates, hospital admission. There was a difference in neoplasia, but probably that led or had nothing to do with the drug used. And just to finish, I wanted to share this algorithm with you from the AGA. For handling elderly patients, they suggest that perhaps this is something we're going to have to include in our practice. We have to assess not age, not number, but the frailty of that patient, his or her condition, whether because of comorbidity, frailty, whatever, whether that patient is a fit or a frail patient. And based on that, we may take our decisions going far beyond age. Take-home messages. Well, elderly patients and populations are going to be a bigger challenge. They are already, and they're going to be even bigger when we see them. They have some specific characteristics, polypharmacy and other issues that we have to take into account. It cannot be coffee for all. They say lower use of biological and immunosuppressive drugs, but studies will have to prove whether this is due to a minor seriousness, lower seriousness, or whether we're afraid of using them. There are relatively few data in terms of effectiveness and safety of biological drugs other than anti-TNF in elderly patients, so we have to take this into account. And real-life data, what's available today, seem to indicate that molecules have a quite interesting and good safety and effectiveness profile for this patient. And that was all from me. Thank you very much.
Buenos días, gracias a todos.
Good morning. Thank you all. Could you please show my presentation? My initial idea was to invite Laura Sempere, who is an expert in women and gender differences, and she has written a lot about gender differences in digestive diseases, but unfortunately she could not come, so she had to call it off, and I'm speaking here on her behalf. So I'm very happy because I really enjoyed the topic and I have learned a lot by reading the presentation. Let's discuss a patient with Crohn's disease who is part of a clinical trial, and by chance on her first visit, I was not there. I was not listening to her. And this is also going to be part of the final reflection. So after vaccination, after COVID-19 vaccination, she told us that she had a temperature and also menstrual disorders. The next time I saw her, 1 month later, in the clinical trial, she still had menstrual disorders. So you keep on listening to other patients' stories, and I came to think to the fact that female patients have issues that sometimes doctors do not take care of, but because she was part of a clinical trial, we had to write it down. And often, sometimes women complain that they have menstrual complaints, but we do not even listen to them. But because she was part of a clinical trial, we had to actually note it down. So Natalia noted those menstrual issues down, and I continued the topic. And this is the basis of my interest in this gender difference with regard to IBD presentations in males and females. So what are the main characteristics of women? They obviously have different hormones from men, estrogens, which have an impact on hormone regulation and immune response. In many cases, they have anti-inflammatory effects, but sometimes hormones have pro-inflammatory effects, such as the increase and maintenance of the autoreactive T cells. So there is a dual effect with regard to the inflammatory response modulation. The immune response is not just depending on estrogens, but also on the progestogens and their levels, so that the T1 or T2 response will vary depending on the moment of the menstrual cycle. So menses is normal, but it does have an impact on the female body's response to the same events that are found in a man. Moreover, estrogens also have an impact on digestive symptomatology because they have an impact on motility, on digestive motility, also on pain feeling, and they have changes in the microbiota. Probably progesterone also has an impact, but the impact is different, and all of that will have an involvement in the symptoms of women compared to the symptoms of men. Moreover, drugs will also have a different response because the pharmacokinetics is different in men than in women. There are differences in the gastric emptying. There are also differences in the proportion of body fat. At the same time, the blood flow into each organ will be different. The hepatic enzymes will be different, and the renal clearance of drugs will also be different. So with the same amount of drug at plasmatic level, the pharmacodynamics will result differently in males and in females. And this has not been sufficiently researched. So the effect of a drug in women, both the clinical effects and the adverse effects, will vary from men to women. And this has not been sufficiently explained or studied in clinical trials. With regard to autoimmune diseases, there are some which have a clear female predominance compared to male presentation. For lupus, 7 to 10, for Graves' disease, also for Hashimoto's thyroiditis, and also not so importantly for multiple sclerosis, rheumatoid arthritis, whereas ankylosing spondylitis is clearly male predominant, just like Reiter syndrome. But what about IBD? Well, Mercedes has shown the same slide. So we can see there is a clear difference between Crohn's disease and UC in Western countries. The Crohn's disease is more frequently found in females than in males in Western countries, except for pediatric age. Probably because after puberty there is a hormonal change. These are all hypotheses which have not been proven. So we just see the curves and we build a hypothesis based on those curves. However, ulcerative colitis is predominantly male. There is a period of time where there's practically no difference, but in adulthood, the rates are similar. And in elderly age, more males present with ulcerative colitis than women. Maybe menopause plays a role in that change. There could be hypotheses towards that point. However, this pattern found in Western countries is not the same in Asian and Pacific countries. It is a meta-analysis considering Crohn's and UC, and we can see that there is a male predominance except for the more elderly patients. Is this because of a biological difference? We don't know. Maybe there's also a difference in access to health services in some parts of the world. We still don't know. What about the risk factors between men and women? Are there differences? This is an old study which shows that males with UC, I mean those males who are non-smokers compared to ex-smokers, in males, ex-smokers have an earlier diagnosis. So we know that smoking could be a protective factor in ulcerative colitis. This has been shown in men, not in women. Whereas in Crohn's disease, there is a more clear trend for women. We can see that the deleterious effect of smoking is more clear in females with Crohn's disease than in men. And women require more immunosuppression. we tend to say that smokers respond worse to treatment, and in the case of the increase in the dose of immunosuppressants is more obvious in women. It is also true that oral anticonception increased the risk of Crohn's disease, and you see, and it's obvious that it's only women who take oral anticonception, so that is why it's an exclusive risk factor for women. Endometriosis at the same time is also associated to a 50% higher risk of ulcerative colitis in women. And this is also true for Crohn's disease. Endometriosis is caused by hormonal alterations, but the treatment is also oral anticonception for endometriosis. Now, what are the clinical characteristics in different countries with IBD patients? Usually women are diagnosed later in life. You can see, for instance, this graph. Blue is for women, green is for men. So, for instance, in China, women with IBD are diagnosed later than men. Then in the Netherlands, which is the bottom chart, there is not a very clear difference. However, we can see that generally in Western countries, incidence is higher in women, and particularly in middle-aged women. And then in China, which is at the top, we can see that women have a lower presentation of perianal disease, and in the West, women have a lower ileal affectation and a more colonic impact, and fewer incidents of strictures. In Switzerland, we can see that women have a protective factor of affectation in L4, and the boy-to-girl ratio shows that Crohn's disease is higher in men, and the other way around for ulcerative colitis. But the difference, the gap is going to become narrower as age progresses. With regard to extra-intestinal manifestations, there are some of them which are very clearly present in women, such as periodontitis, anemia, cardiovascular disease, the need to compensate for nutrient deficiencies, oral cancer, colitis, joint affectation, except for ankylosing spondylitis, which is more frequent in men. It is also more frequent for males to present with osteoporosis compared to women, probably because of the risk compared to the general male population. Although, as we know, osteoporosis is more frequently found in women. If you compare men with IBD, they more frequently present with osteoporosis, and at the same time, also cardiovascular disease. It seems that the prevalence of cardiovascular disease in women with IBD increases much more than for men. So what is the evolution of these patients' complications? Women in our study, which corresponds to a Dutch database, women required less prednisone and more budesonide. It seems that women are receiving fewer immunosuppressants, and there are fewer adverse effects with immunosuppressants. Women also receive fewer anti-TNF, and I'm reading here that they use fewer biological drugs, such as vedolizumab. They also need less surgery than men, usually less intestinal resection at the level of the ileum or ileocecal, and they usually have fewer serious complications such as intestinal perforation. Let's look now at the long-term course of the disease, and I'd like to draw your attention to the impact of the menstrual cycle and menopause among women. 1,100 women were part of this survey from the USA, and 50% of women reported a worsening of the IBD symptoms during menses. Not necessarily correlated with a higher activity, but with a worse symptomatology during menses. More than 50% of women reported that. During ovulation, 20% reported a worsening of symptoms, and during menopause, 15% of women reported an improvement, while 21% reported a worsening. So, which actually means that menopause is worsening the condition for some women and improving it for others. So, when we think about women, we have to also consider sexual dysfunction. It seems that women have worse scales of sexual satisfaction. This is sometimes disregarded in clinical practice, but it's a question that should be posed to women. Women with IBD usually report more pain during sexual intercourse, less lubrication, and this is something that is actually not asked to women when they come to our office. And I think we should provide more care to sexual dysfunction in female patients with IBD. I used to think this would be more related to menstrual issues, etc. But we can see that men also present with sexual dysfunction because of IBD. During the flares, the scores of sexual dysfunction is higher, obviously, and certainly higher than during remission. There are also differences with regard to the gender differences of IBD between male and women. There are differences also with regard to extraintestinal manifestations. There seems to be also a difference in the management and treatment, particularly with regard to the use of biological drugs and anti-TNFs. And we should bear in mind other issues in women, such as the evolution during their menstrual cycle, as well as sexual dysfunction and other aspects such as pregnancy that I have not touched upon. And finally, take-home message: knowing what makes us different helps us to treat each other as equals. That would be the take-home message for all of you. Thank you.
And now I'm introducing you Aline Charabati. Aline comes from Washington, D.C. She is the head of the IBD unit in the Johns Hopkins. I never know how to say this, Hopkins. And she's a very active doctor in the clinical and also in social media, but she's a true advocate and defender of women and also of minorities, and he's very interested in how disparities and different ethnicities live with IBD. So I invited her to give us a talk on this subject, and you will see that it's something peculiar because she has not only searched for what happens in America, but...
All right. Good morning, everyone. Thank you so much, Vincent, for having me, and congratulations to you and your team for organizing a wonderful symposium. And thank you for the people in the back and translating, and I was able to follow all these wonderful talks today. And I learned a lot preparing this talk about the wonderful IBD care in Spain. But the most important thing I learned is that Vigo has the best Christmas light in the whole world, better than New York City. So I learned that yesterday, and I'm taking this back home. So my goal today is really to talk about the differences in IBD risk, presentation, and natural history in the different groups in Spain and in minorities in Spain, and share with you a little bit our experience with IBD in minorities in the United States to really highlight how social determinant of health actually affect IBD care, and brainstorm what we can do to minimize health inequities in IBD. So All right, so in Spain, what I learned is that the incidence of IBD has really increased. It has doubled in the last 10 years. And in 2017, the incidence was 16 new cases per 100,000 inhabitants. So it's becoming very similar to countries in Northern Europe. And what's interesting is more than 40% of patients who are diagnosed have to use immunomodulator or biologics within the first year of diagnosis, really highlighting that these are more, when we're diagnosing patients with IBD in Spain, we're really dealing now with patients with moderate to severe IBD early diagnosis. However, when I try to find data about minorities and ethnic minorities in Spain, there's limited data because, as you know, in Spain, the data on race or ethnicity are not included in the official registration records of citizen. But we'll talk about the data that's available in minorities such as the Roma population and immigrants in Spain. But before that, I wanted to review with you some terminology so we can all understand what we're talking about, because often these terms are used interchangeably, but they actually don't mean the same thing. So when we talk about health disparities, it means there's a higher burden of disease, higher injury, disability, or mortality between different groups. Okay? When we talk about healthcare disparities, it means that some groups are not able to access quality of care in their system. Health inequality means any measurable aspect of health that differs from one group to another, whether this is fair, unfair, just, or unjust. This is a health inequality. Health inequity is the main problem. It's where health inequality is due to the fact that we have a health or social system that's not fair or that's not just toward one group. All right, and we can have health disparity without inequity, or we can have health disparity because of healthcare disparity and inequity. So hopefully in the next few slides I can show you some examples of that. So if we talk about incidence rate of IBD in different areas of Spain, we see that some areas have a higher disease burden. In some areas, the incidence is much higher than in the general Spanish population. For example, in these areas that I highlighted here, I'm afraid to mispronounce them, but like Castilla-La Mancha, Asturias and Navarra have a higher incidence of IBD. This is an example of health disparity. Certain populations have a higher incidence than others. And in the same study, we see that patients with Crohn's disease that are hospitalized in hospitals with low or high resources receive different medical care. So patients with Crohn's disease admitted to hospital with lower resources have a higher use of mesalamine, lower use of steroid, and lower use of biologics, despite the fact that the patient characteristic in terms of phenotype and disease severity were similar across these hospitals. So that can reflect a different pattern or different way of treating in different hospitals within the same country. If we compare IBD in patients from different environment, we know that if we look at worldwide population, there's a higher IBD in urban cities compared to rural areas. But I like this study. I find it very interesting because it compared different life setting, rural or urban, coastal or inland, within Galicia. So it's within a group that has a similar genetic makeup. So really to highlight how the environment has an effect on IBD. And without going into the details, we can see that depending on where you live, your risk of Crohn's or UC is different. The phenotype, the disease location, the disease severity is different. The presence of extraintestinal manifestation is different, and in patients with Crohn's disease, requirement for more effective therapies such as immunomodulator or anti-TNF is different depending on where you live. So these are example of health inequalities. So people living in different environments have a different disease burden and disease experience, and that's likely due to pollution difference in diet. We know that in urban environment, we tend to eat more junk food, processed food, quick food, versus people living in more rural area tend to have, their own gardens, they eat fresh fruits and vegetables. Lifestyle, whether we're smoking or not, whether we're exercising, physical activity, walking within our environment or driving cars, and the hygiene hypothesis. So excessive hygiene tend to increase our risk of IBD. But in this example, we do not see healthcare disparity. So we don't think that this is due to lack of access to care, because in Spain, you are lucky you have universal access and free care. And also, all these hospitals in the study take care of patients coming from different environment without, without making a difference in decision whether people live in inland or in the coastal area. So we talked about Galicia. Let's zoom into Vigo. And this is the data from the EPICOM study. It's a population-based inception cohort of unselected IBD patient that was developed within ECHO, and Vigo it was the only Spanish site. And in 2010, what we see is that the incidence of IBD in Vigo in patients above age 15 was 21 per 100,000, so higher than the national average. And what was even more interesting is that Crohn's disease at diagnosis, up to a third of patients when they were diagnosed with Crohn's disease have already complicated Crohn's disease. There was a higher incidence of stricturing and perforating disease. The other thing we can see here is that Crohn's disease incidence is increasing in Vigo versus UC, ulcerative colitis, is relatively stable. And what I find also very interesting, if we look at the peak of incidence, we're all familiar with the bimodal peak of incidence in IBD, first around age 20, 30, and then later in life. But it seemed that in Vigo, there's a peak with every decade of life for Crohn's disease. And for UC, the peak is limited to between age 20 and 30, and then it seems that the incidence is lower as we advance in age. Switching areas, IBD in Catalonia. This is a population-based registry that included the entire population of Catalonia. And what we see here again is that the prevalence of UC and Crohn's disease have been increasing and is higher than what we saw in prior Spanish studies, and is among the highest in Europe, but still lower than the United States. And there has been a 37% increase risk of or incidence of IBD in the last 6 years, and the prediction is that in the next 10 years, the number of people with IBD is going to double. So as a healthcare system, it's important to know that and know how to prepare for that increase in the number of patients with IBD. So let's talk about IBD in minorities in Spain. First, I'm going to start with the immigrants. This is a prospective multi-center study that compared patients with IBD that were born outside Spain, so first-generation immigrant to Spain, and compared them with native patients. And in terms of immigrant, the most common ethnicity was Caucasian, followed by so people coming from different countries in Europe to Spain. Latin America, Arabs, with the most common being Moroccan, and Asian. And what was found very interesting is that for immigrants, compared to native, immigrants were diagnosed at a younger age with IBD. And immigrants that came to Spain when they were younger than age 15 had IBD at an earlier age, as opposed to those who immigrated after age 15. Family history was less common in immigrants, and they had more extraintestinal manifestation. Immigrants had lower rates of smoking, and I think maybe that's playing a factor in the fact that they had less stricturing Crohn's disease and less need for surgery. But interestingly, they had a higher use of biologic compared to natives. And then I looked at immigrants, so people living in Galicia who left Galicia and then came back. What happened to that group of people? And we see that people who left Galicia to work in other countries and for more than 1 year and came back have a higher risk of developing IBD compared to people who stayed in Galicia. And that was mainly driven if people left Galicia to go to European country, but not to Latin American country. And that majorly played a role in developing ulcerative colitis, but not Crohn's disease. So we see here whether you have immigrants coming to Spain or Spanish going to other European countries, the fact that exposure to the industrialized country lifestyle and diet and everything else is probably playing a role in the development of inflammatory bowel disease. So let's talk about the Roma population of Spain. This is a study looking at IBD database of 7 Spanish centers, with most of these centers being in areas where there's a high Roma population. And the mean age of diagnosis in the Roma population was 25, so similar to what we see in the general population, and 54% of patients who had Crohn's disease were active smokers. But what was interesting is that these main things were that there was a higher familial aggregation in the Roma population. So familial aggregation meaning you have a first degree or second degree relative with IBD. And we see that in 43% of the Roma patients compared to only 9% of Caucasian patients. And Roma patients had a higher number of relatives with IBD, a mean of 2 compared to a mean of 1 in Caucasian. And there was a high concordance of IBD. So if you had somebody in your family that had Crohn's, you have a higher risk of having Crohn's as opposed to UC. So this could be due to the fact that the Roma community is very homogeneous, a lot of intermarriage, a lot of consanguinities, and so maybe they share similar genes. And there's a hypothesis that they have similar genes that affect ulcerative colitis and extraintestinal manifestation. We'll see in the next slide that patients with UC had a higher risk of having extraintestinal manifestation. And actually, there are studies that found that in Roma patients had a different distribution in the frequency of haplotype to the IL-23 receptor gene and to the genes that are responsible to respond to steroid. So that can actually affect how we treat these patients, knowing that they might respond differently to steroid or IL-23 inhibition compared to Caucasians. So more on the IBD in the Roma population, where we see in UC there was a higher incidence of extraintestinal manifestation, and in terms of therapy, they were more frequently on thiopurine. And for Crohn's disease, there was a high incidence of complex Crohn's disease, stricturing, and mainly perforating disease. So the question here is, when we're talking about IBD in minority and how it's presenting, is always, do people from the Roma population have a more aggressive disease, a more aggressive phenotype genetically, or is this due to other factors, such as delay in seeking medical care because of maybe cultural barrier or poor health literacy, or people not interested in seeking care in a medical system? Or do they have limited access to care, or is there a decreased compliance in this patient population? So that brings me to what are the causes of disparity of IBD? And they're really multifactorial. So due to patients, due to physicians, genetic differences, genetic predisposition, different environment, like I show you, where you live, how you eat, phenotypic differences are present, and difference in how people perceive the disease, how comfortable they are talking about the disease, seeking medical care, managing, knowing when to call the doctors, when to come to the emergency room, and difference in adherence to medical therapy. And of course, it seems that in Spain, with the universal care and having IBD specialists throughout Spain, patients have access to medical care and IBD specialists. This is more of an issue in the United States, where there's limited access to IBD specialists and a high financial burden on patients, and we'll talk about that. But often there's a delay in seeking care because patients with diarrhea think they might have IBS or food intolerance, or maybe they're embarrassed to talk about diarrhea with their doctor, or they're not able to see a physician for different reasons. And we saw in the data about different therapies in different hospitals, how we as professionals, provide care can be different depending on where we practice. So all these factors can really lead in delay in diagnosis and delay in starting effective therapy, and lack of access to multidisciplinary, continuity, high-quality care in IBD. So I want to share with you, the next few slides, our experience in the United States. Overall, we have 2 million people with IBD. The annual incidence is higher in white than in non-white, but the increase in the incidence through the last 40 years has been the highest in non-whites. So the incidence has been increased by 39% in white, but it has increased by 135% in non-whites. So blacks and Hispanics in the United States, this is really where we're seeing the highest increase in IBD. And actually in 2050, we won't be able to call blacks or Hispanic minorities because they actually will make more than 50% of the US population. So it's very important for us to understand what's going on in IBD in our minorities. So what we know from the data, again, very limited data because it's only recently that the US became interested in understanding IBD in minorities, but minority patients often present with more complication and more advanced disease. So why is that? It seems that one, there's often a delay in diagnosis and in starting treatment because patients have a delay in seeking care because of cultural barrier, being embarrassed to talk about maybe diarrhea or bleeding to a physician. But also because often, and I'll show you, patients, minority patients in the US often are poor and have poor education and poor understanding of medical problems and have limited access to care. But also as healthcare physicians, many of us still don't realize that IBD is not only affecting Caucasian, but it can affect any race, any ethnicity throughout the world and in the US. And unfortunately, we live in a society where there's still a lot of racism and there's often a bias toward minority presenting with symptoms. We have data showing that physicians assess health literacy, meaning whether the patient understands the medical problem, understands the treatment, more often in white men than in women or in minorities. There's often a delay in starting treatment in minorities, and there's a low follow-up rate. So we don't tell patients, black patient, Hispanic patient, this is when you need to come back. We can give them a treatment without real indication when they need to come back. And most of this is really driven by the low socioeconomic factors. Up to a third of Hispanic and African American live in poverty compared to whites, which means that they don't have good insurance, they are underinsured. So in the US, we have a system called Medicaid that is given by the government for people who are very poor. But Medicaid had a lot of limitation because it's not taken by a lot of physicians. So a lot of physicians do not see patients who have Medicaid because Medicaid doesn't reimburse properly. The second thing is that Medicaid does not give you access to all treatments and does not cover 100% the cost of the treatment. Or if you're poor but not very poor, then you do not qualify for Medicaid anymore, and you have to pay for your own insurance. Insurance is expensive and also does not cover 100% of the cost of care. So if you are poor, you also live in areas where there's very little gastroenterologists, let alone IBD specialists. So you can imagine if you have to pay for expensive biologic, if you have to pay for your visit, if you have to drive 3 hours, or maybe you don't have a car actually to be able to drive 3 hours to reach a gastroenterologist or a IBD specialist, then access of care is very limited. So there's a delay in seeking care, delay in getting effective care, and people wait until they're very sick, and then they go to the emergency room and they get hospitalized. So you see here data showing that blacks have a higher incidence of being admitted to the hospital because of IBD compared to whites. And the use of steroids in black and Hispanic and patients who have Medicaid insurance is much higher compared to white, probably because these patients don't have access to effective therapy that would prevent them from having to use steroids. And so if you look actually at the use of immunomodulator and anti-TNF in blacks compared to whites, it's lower. But if you look by insurance, so those who have Medicaid, whether you're white or black, your rate of using effective therapy is low. So it's really the socioeconomics that are driving the disparity of care in our patients from a minority. So looking back at this data, how there's a delay in seeking care, this has very serious consequences, right? So there's a higher mortality in our minority patient admitted with IBD. There's a higher incidence of IBD-related complication, and there's a higher disability because of IBD in minority patient. So this is really an example of health disparity. There's higher disease burden in our minority patient, higher disability, higher mortality. There's healthcare disparity. Minorities in the US have decreased access to high quality specialty care, and there's health inequity, because all this is due to the fact that we have an unjust and unfair system, and poor people don't have access to good care. So this really brings me to the concept of social determinant of health. These are non-medical factors that affect the outcome of IBD care. You know, your environment, your economic situation, do you have a job, do you have insurance, do you have a car, can you afford good food, your environment, where do you live, in the urban area or rural, do you live in a place that's safe, that has playground? We all know that contact with nature decreases the risk of IBD. Do you live in a very remote area where there's no access to a primary care, to a GI specialist? Your level of education, how well you understand the medical terms that are communicated by your physician, how proactive you are in making sure you remain healthy. Nutrition, you know, we all know that junk food is cheaper than fruits and vegetables and healthy eating. And this affects the risk of having IBD. Do you have social support? Is there somebody who can take care of your kids so you can go spend 2 hours in the infusion center? Or are you a single parent and you can't leave your kids after school to go get your treatment or see your doctor? And how good is your healthcare system? Do you have a universal healthcare system, or is there disparity in accessing that healthcare system? And all this really affect health outcome. So with the increasing prevalence of IBD in different groups and racial and ethnic minority, understanding the social determinant of health and how it's important to be aware that minority are also affected by IBD, and the fact that we have healthcare disparities in the US, all this really lead to poor IBD outcome, higher mortality, higher disability in IBD patients who are from a minority population. And so it's very important to be conscious of that and do something about it. So I know maybe I'm running over time a little bit and I'm keeping you away from your break, so bear with me for a few more slides. What can we do? Is when we see patients in clinic, it's important to ask them beyond number of bowel movement, blood in the stool, abdominal pain. It's really important to understand their social history, right? Are they single, or do they have support? Do they have children? What kind of work do they do? Do they have means of transportation? Are they able to come for their visit? How far do they live? And so to understand how these can really affect the type of care that you're going to be able to provide to these patients, and really work with your team, with your nurses, with your social worker to facilitate access to care to patients who have social determinant of health that works against them. And really educate the patients about their disease, about treatment, and make them proactive in their care. So it's very important to communicate with the patient, and really at a level that they understand from their level of education, whether you use visuals or videos or handout, really find how is the best way for the patient to understand their disease and understand their medical plan, and double check that the patient understands. So talk, ask, can you tell me what you understand? And then have this communication. And as clinicians, as physicians, as nurses, really become educator of the patient. And this leads to what we call patient activation, meaning when the patient understands their disease, they understand why they're taking the treatment and what is the course of action, we want them to be active. We want them to be partner with us and making the decision and following up, etc. So this is different than patient adhesion or compliance, when we make them follow up and make them take their medication. We really want the patient to be proactive in their care, because what the data has shown that patients who are proactive have a better outcome in terms of their IBD. They remain in remission for a longer period of time, regardless of their other risk factor, because they also adhere to treatment and they're more compliant with what we recommend in terms of disease monitoring. The other thing that's important is really to increase diversity in our GI representation. You know, the same way we make effort to have more women, we also want more minorities in GI. In the United States, most gastroenterologists are whites. Blacks and Hispanic make less than 10% of all gastroenterologists. So there's now an effort to include more minority in the field of gastroenterology. And finally, you know, really look at things broader. So we're looking at how we can make things better in our clinic, in our GI profession, but also at the society level, really include patients from minorities in the patient advocacy group, in patient education, because we all know that representation matters, right? Where we hear things from a physician or from a patient that look like us, that is from the same area, from the same ethnicity, we trust more, we understand more, etc. So it's important as a health system to really address our biases and have be educated about how different culture understand disease differently and how it's important to approach patient within their culture without judgment to improve the care of IBD in all our patients. Thank you very much for your patience and for having me today.
We are a bit late. If we wish, we can. I was thinking in making some questions answers at the moment, but perhaps as we have an hour debate afterwards, so you can write your questions. También lo digo en español. Luego tenemos un debate de 1 hora.
We're going to have a 1-hour panel discussion, so maybe, if you please, we're going to take a break right now, and we will leave the Q&A for the last part of the morning, and we're just going to break for coffee for 20 minutes. Thank you very much.
Hola. ¿Podemos sentarnos?
Please be seated. Thank you.
Naila Erebi comes from London, from St. Mark's Hospital. He's the director of the IBD unit at St. Mark's. And she's a researcher on epidemiology of IBD. He was chair of the EPICOM committee of ECHO, and she's chair of the IBD study and cooperation group. So she has prepared for us it's a presentation, but we will ask you to participate with us, because this is a kind of how to develop or how to prepare an epidemiological study. How can we use different tools to participate on this? You were receiving some papers, so afterwards we will work in little groups or big groups, but first of all, Naila will show us, will talk us about core outcomes score.
Thank you, Vincent, and thank you all of you for being here today on your weekend, so I really appreciate it. And also thanks for the organizers for inviting me. It's an absolute pleasure to be here. My colleague Alina was fascinated by the lights of Vigo. I was fascinated by the escalators of Vigo, and I look forward to retiring here in the future with my arthritis. I've been asked to talk about Eurocare for observational studies and how to incorporate the newly developed core outcome sets into the talk. You'll be pleased to know I'm not going to talk for an hour and 15 minutes, as is on your program. You'll not be so pleased to know that I'm going to make you do the talking for some of the time. So it'd be nice to interact a little bit, although I appreciate it's difficult within this auditorium. So what I've done is I've divided the talk into 3 sections. The first section, I'll just give a bit of overview about outcomes and the core outcome sets in IBD, particularly the development process for observational studies. And then I'll demonstrate the use of the Eurocare database. Just as a hands up, how many people have heard of Eurocare? If you put your hands up. So, so maybe a quarter of people, not so many people. And of those people, how many have actually used it? Probably nobody, no, okay, that's fine. And then I'll give you a few examples of Eurocare in real-world studies, how it's been used by, as a clinical registry and and for research studies, and then I've got some case studies for you to work on, if you like, okay? So the term outcome encapsulates many meanings, and the primary definition of an outcome, if you want to just sit back and think about it, is that it's an event. And it's an event which is used to describe the natural or the clinical course of disease, something that happens to a patient, and it is really mainly focused on a patient, either naturally or because of an intervention. And we talk about various types of outcomes. So the hard outcomes refer to things that says yes or no, it's happened or not, and it's easily visible, such as mortality, a disease recurrence, complications, or even remission of disease. And then there are surrogate outcomes, which are biologic markers, which indicate that something clinical has happened. And these are changes in lab values, blood pressures, for instance, change in size of a tumor. In IBD, we have things like fecal calprotectin. Those are considered surrogate markers. And sometimes we also used what are called soft outcomes, which are becoming increasingly important because they reflect the patient's voice. So this is the quality of life, the functional status, and other patient-reported outcomes. There are some composite outcomes or composite endpoints where a series of outcomes are put together. For example, in IBD, you'd have a clinical remission with CRP on a fecal calprotectin to show actual remission. So that would be considered a composite outcome. The primary outcome is the key outcome that will answer your research question, and it is designed depending on the design of the study. And then lastly, we have health economic outcomes, and these include healthcare utilization, how many services you're using, but also expenditures. Now, the choice of outcome depends on several factors when you're designing a study, but primarily your research question. So your primary outcome is related to your primary research question because you have to answer it with one measure. But it also depends on the study design. So if you have interventional studies, you might opt for an outcome such as clinical remission, endoscopic remission. It also depends on observational studies. There are different types of observational studies. So if you're using a case control study design, then generally you want a single outcome because it has to be evident in the control plus in the case. In cohort or cross-sectional studies, you can use multiple outcomes, and you generally define them into the primary and secondary. In crossover studies, because it is a continuous process with an exposure and then without an exposure, the acute outcome has to be within a time period of the exposure. And so you can appreciate here the heterogeneity in all the reported outcomes, and this creates two problems for us. Firstly, when you want to collate all the outcomes to create a systematic review, you may find that some studies can't be included because you don't have the outcome of interest, and that limits our generation of high-level evidence for systematic reviews. But also, it creates a problem is that you can't pool data from different data sets together because they are all capturing different outcomes. And there have been two really key initiatives that have tried to overcome these barriers, and these are development of core outcome sets and also the development of a universal database. And that's what I'm going to go to next. So a core outcome set is an agreed minimum set of outcomes that should be measured and reported in all studies. So if everybody captures the same outcomes, and you have 10 studies, and the same outcomes are captured in those 10 studies, then you can use all those 10 studies for systematic review. But they are including relevant outcomes for that health condition within a specific setting. So for instance, perianal Crohn's disease treated within a hospital setting. So you have to be really careful about the setting of the outcome. And this will overcome some of that diversity that stops us from harmonizing our data. We do have core outcome sets in IBD, and there are several core outcome sets in other specialties. It was started initially in the rheumatology discipline, and they were primarily designed for randomized control studies. And in IBD, they are designed for clinical trials in UC and Crohn's disease, but also for some specific IBD conditions, such as perianal Crohn's disease. But they do fail to capture sometimes the concepts that are relevant to patients over a long period of time, which is the natural history, prognosis, and very importantly, safety, because those are not randomized control studies. You don't get that data from randomized control studies. You get them from observational studies, and there were no core outcome sets for observational studies, not within IBD, not within other literature. And if we had this, then we can harmonize and unleash the power and the potential of large data sets. So ECHO supported this core outcome sets consensus process for real-world studies. I was at the time the chair of the EPICOM committee, and together with the chair of the ClinCom committee, we embarked on this 2-year journey of developing core outcome sets. It started in 2022, so it started 2020, just towards the end of 2019, where we developed a steering group. We undertook a really exhaustive literature review, and my fellow Charlotte went through an enormous amount of literature and honed it down to over 300 papers where she extracted all the data. We submitted the manuscript for the systematic review for publication, and that was published early on this year. And then that started the second phase of the consensus meetings, where we put a list of all the outcomes together and we voted on them in the first and second round, and then any residual outcomes which weren't agreed and were in the middle, we had a consensus meeting and decided on those. And we've come up finally with an ECHO position statement for core outcome sets for observational or real-world studies in IBD, and that's just been published online in October, so a few weeks ago. So this slide really just shows the fruits of our labor. And we divided outcomes into domains because it makes the data more manageable. And we identified 9 domains for this core outcome set. And the domains covered disease complications, disease activity, patient-reported outcomes, specific symptoms, and healthcare utilization. The other 4 are on the next slide. And you can see like examples of some of the outcomes, such as the presence of a stricture, the presence of a fistula. You can either report it as incident or prevalent. I'm not going to go through all of them in detail, but for instance, for disease activity, you can see clinical remission, steroid-free remission, endoscopic type of disease activity, biomarkers, and radiological. And the same for the other domains. Here are the 4 remaining domains, which refer to medical therapy, medical therapy-related safety, and then surgical therapy and safety after surgical therapy. And so outcomes for medical therapy would include things like drug discontinuation or survival, escalation, and steroids usage. The safety are what you see generally in your clinical practice, which is adverse reactions, infusion reactions, anaphylactic reactions, infections, and also malignancies. And similarly with some surgical interventions. So these are the outcomes that should be captured as a minimum for these type of studies. So that leaves us with the question of how we bring all this data together. We still have another barrier because if you're collecting the data on different databases, it's very difficult again then to integrate and to pool the data. And ECHO carried out a survey a few years ago looking at registries across Europe. And they asked about things like mortality registries, birth registries, twin registries. But the focus really was on the IBD registries, and there were IBD registries in 19 countries across Europe, with 15 of them having a biobank linked to the registry. So they set out this really ambitious and really forward-thinking task of trying to create a pan-European database. And this is how Eurocare arose from these initial studies. So Eurocare databases was intended for clinical care and extended also for collaborative research studies and has huge potential. It's free and it's web-based. At present, we have over 7,000 patients, and you can see the number of sites activated starting in 2019 and up to 2022. And this is the last Eurocare newsletter that was sent to the committee. And there are several research studies using the Eurocare platform. So the Belgian group have embedded it in their BIRD program, which is the Belgian Inflammatory Bowel Disease Research and Development Program. And they're using it also and linking it to their biobank. And I'll show you how they've done that in a few minutes. We're using it in the MIRACLE study, looking at pouch outcomes. There's another study called the SIDE study. And there are some groups that are also using it as a national database. So in Greece, I understand it's being increasingly adopted, and I'll show you some data from Slovenia. So now we have all the pieces of the jigsaw puzzle together. So we've got some core outcomes with their linked outcome measures, and we've got a universal database, and all these can be linked together to address and answer some really, really important research questions. Sorry? Okay. So you can access the database through the ECHO webpage. There is an introduction about it. It gives you an overview of it. There's also a demo version that you can log in and you can play around and see how you would work with it. And then I have my own login, my own personal login details, because all I can see is the patients in my center. So if you have patients from your center or Eurocare, you can't see my patients and I can't see yours. But if you and I talk and we want to do a study together, then our data will be collated and we can do a nice big study together. So I'm just now going to give you an overview of the database. So this is what I see when I log on. So you can see here you have projects. That's the admin section. And so if you and I have done a project together, then we will get our own tab over there and we can work aside I don't know why I'm looking at you, but I'm just looking straight ahead. We can kind of log on to there and interact there. You have an image here. You can put the logo of your center over there, and then you have the search box here. Just below here, you can see the number of cases included. So we really took off in 2022 because we are part of the Miracle study, but we also conducted an inception cohort study looking at educational intervention on patient activation. So we checked patient activation measure at baseline, gave them education, and measured patient activation later on, showing that patients were more educated or more engaged with education. And then you can see the number of cases overall in Eurocare. So I know that of those cases, that will shoot up when the ENADA registry will join with Eurocare, but they're still working on methods of integrating that data. So ENADA will eventually, hopefully, move onto Eurocare, and that will shoot up the numbers there. So these are the kind of different menus. You have add a patient, the patient list. So that's kind of like the day-to-day interaction. These are also very useful tabs because at the touch of a button you can get statistics about your center, and I'll show you an example. You can see how many IBD patients have, how many have left-sided disease. You can create filters to ask specific questions such as how many of my ulcerative colitis patients who have proctitis have used infliximab and then used tofacitinib, for instance. So you can put that query in and you can get the answer to the touch of a button. And you can export your data as an Excel sheet, and this documents box has the information about the Eurocare and also the consent form. So this is what you get when you when you put your patient details in. When you want to add a patient in, this is what you'll get. So that's my center. And patients need to be consented for this because they need to consent to you collecting the data, but also using it for the specific purposes of clinical care or whatever it is you want to use it for. If you tick no, you stop. You can't do anything else, okay? If you tick yes, it will open up this. If you tick not required, that means that the patient is in a research study and they may have been consented within that separate research study. Okay, so this is what you need to add for the patient information, the name, the second name, the country, date of birth, and gender, and the date of inclusion. There are other things you can add if you wish, but that's really much the basic data that you really need to add. And once you add that, you will have this menu coming up, which is the key menu options, which is the patient tab, the disease characteristics, endoscopy imaging, conventional treatment, immunomodulators and biologics are separate, surgical treatments, follow-up, comorbidities, screening for infections, and then anything else you can add over here. The problem with this is when you come to search it, there may be a limit in what you can search. So I'm just going to give you a little bit of an example here before we do a joint sort of case. For example, so we've put that patient in and you want to add the disease characteristics, so you click on there, it will open this tab here. This patient has Crohn's disease and you get the location, and I decided that this patient has terminal ileal Crohn's disease. I think that's probably just a mistake. We'll just stick to terminal ileal Crohn's disease. He may have had an operation later on. And then you'll get the behavior of the disease. Yeah, so inflammatory, stricturing or penetrating, and you add that and the date you've noticed it, and other complications related to disease characteristics. If it's ulcerative colitis, for instance, again, similar location, and you also have potential complications with ulcerative colitis. And once you save this, so I saved the ulcerative colitis, what will happen is you have the disease characteristics. You'll see that the patient at the upfront, when you open your screen, has ulcerative colitis, and then in the future, if something changes, so this patient had proctitis, yeah, so they may develop left-sided colitis, they may develop pancolitis, or you may realize you got the diagnosis wrong and the patient has Crohn's colitis after all. So you can't change it, and you can see this when you log on, it will appear over here, so you can get an overview of the patient when you log on. So I'll just show you another one, which is, so that's your original menu. There are some that when you click them, they'll open up another tab. So for endoscopy, for imaging, for immunomodulators, biologics and surgical treatments, and also pregnancy. So that when you log on the next time, you can immediately see and get an overview of what's happening to the patient. So here I'm adding that the patient started a biologic. You can decide which one. You can decide the name of it if you want to. IV, because he got ulcerative colitis and was very sick. Luminal disease, the date start, and then I also optimized his treatment. So the next thing is to also add the follow-up and laboratory tests. So this is what happens when you click on this tab over here. Okay, so you'll get this window opening, and that's all the type of information that you may want to enter. You don't have to, but it depends on what you want to look for in your patient group. And then at the bottom of this, you have some information about treatments. And what I've done here is I tried to link it with some of the outcomes that we spoke about, so the core outcome sets. So if you're looking at a study looking at disease complications, you definitely have to include this tab. Whatever you're looking at, you must always include the patient and the disease characteristics. The rest really depends on what you want to focus on, just to make it a bit easier. So you can have a level 1 of data, and then you can have a level 2 of kind of more detailed data. If you're looking at specific symptoms or patient-reported outcomes, you definitely want the follow-up, because that's where that detail goes in. If you're looking at disease activity with an intervention, you'll need the follow-up, but you'll also need some of the treatments. And then healthcare utilization actually captures everything, because you want to see how active the patient is. And then likewise, for the other 4 domains, medical therapy, you have to definitely include the treatments, the safety aspects, so you want to look at complications here. You might want to look at pregnancy complications. And similarly for surgery, you definitely want to include those 2 tabs in your patients. So that's kind of like an overview of the database, if you like. I'm just going to give you an example here from one of our EuroCare users meetings, because these are held regularly now, from the group in Slovenia, who did an enormous job of capturing all their patients with IBD, and they managed to capture 1,000 patients. And this is what they were able to do with the database. So they identified 1,000 patients. They looked at the treatment and identified 814 patients. They analyzed the age of the patient, the gender distribution. 10% had relatives with the disease. Here you can see the location of Crohn's disease, and on the right-hand side, location of ulcerative colitis. And this is all data that you can get just at the touch of a button with the statistics tab. They also were able to see the pattern of prescribing biologic drugs. So first line, second line, third line, fourth line, the number of patients, and how many started with anti-TNF, vedolizumab, or ustekinumab. And again, this is really easy patient data to acquire from just the touch of a button. They also looked at changing trends in biologics. So in 2019, 2019, they had no restrictions about prescribing which first-line biologic drug. So they were able to see that before 2019 and after 2019, that actually there was not really much change in the prescribing of anti-TNFs and vedolizumab. But certainly between before 2018, the use of vedolizumab increased compared to before 2018. So they were able to see some changes in patterns. They also looked at drug persistence before 2019. If we just look at after 2019, where there was equal access to all the biologics, you could see that ustekinumab had the highest drug persistence in this group. So this was a first report of prospectively collected data from the EuroCare registry. They were able to study their biologics usage. They planned to adopt the register across Slovenia, and they're now going to acquire some deeper insights into the epidemiology of IBD. So I was just going to try and interact here about entering data and visualizing data for the clinical registry. So this is a case of a 22-year-old male who came with pain and diarrhea. His mum had ulcerative colitis. Those are the blood results, CRP and calprotectin. The colonoscopy showed severe inflammation in the terminal ileum with some mild stricturing. MRI showed similar changes with some pre-stenotic dilatation. Came to clinic for the results in June and was told the diagnosis of Crohn's disease, consented to the Eurocare database at that point in time, calculated the HBI score, considered him for enteral nutrition, and was given steroids. So, shall I give you a little bit of time now? Do you want to maybe just discuss within the person next door where you might, which tabs you might use to enter this information into your care? Yeah, so if I give you a few minutes to chat, so where would this go, where would this go, where would this go, which parts of the menu would you want to use? I'll just give you a few minutes.
Bueno, la idea es con la gente.
So the idea is for you and your colleagues to discuss the clinical information. You can see the tabs where you can actually enter the pieces of clinical information or how you would do it.
We don't have your care, but we have ENEIDA database, and it's quite similar to this.
Oh,
so
okay.
I think that we changed the format of ENEIDA because of your care, just to merge both database in the future. So we are used to that kind, so it would be easier for us, but I hope. Vale, entonces, les estaba diciendo que tenemos en España, no tenemos...
I was saying that in Spain we've got ENEIDA, which is similar to your care. It's practically the same. Maybe you have, Diego, you have been working with ENEIDA, and it's pretty similar, isn't it? So those of you who are not so much used to entering data, you can practice with that now. So now basically we can play with the database if you want.
Okay, shall we try and do it together then? Okay, so 22-year-old male, where does it go? Patient characteristic, yeah, patient, yeah. Smoker, I didn't show you that, but it also goes with the patient. Pain and diarrhea, it's a symptom, yeah. So if you have an encounter where you found the symptom, then you would put that here with the follow-up information, okay? Mom has UC, it goes with the patient characteristics, blood test and calpro, that's a follow-up and blood tests. Colonoscopy, that's an easy one, it goes in there. MRI goes in there. I didn't show you all the tabs for MRI, but there is there's a free field that you can write in, or you can actually tick boxes. Came to clinic for results is another clinical encounter, so you put it in here. The date of diagnosis, I suppose, then will go in there. Consent for Eurocare goes in there. HBI score goes in there. Enteral diet, where does that go? Treatments, yeah. It's under conventional treatments. Under conventional treatments, there's 5 ASAs, steroids, and enteral nutrition. And also prednisolone goes over there. Okay? So it's actually, you know, it's quite intuitive, if you like. And this is what you get at the end of that exercise. You can create a report which summarizes all the data that you've entered. So then comes for another visit, admitted to a hospital with obstruction, started on IV steroids, TPMT was low, started at anti-TNF, and then discharged home. So where will we put these? We could do this together. So hospital admission, I suppose goes there, isn't it? It's a clinical encounter, yeah, with follow-up, yeah. And obstruction is with it because there's the symptoms there. IV steroids goes there. This is a result, so it will go there. Anti-TNF goes there, and you can specify which one. Discharge, there's kind of no place actually to add that. And so, yeah, so that's the sequence that you would put them in: patient, conventional follow-up, conventional treatment, and the biologics. And this is just really to show your patient list when you want to then come back and find the patient or add the follow-on data. So when you've already registered the patient and they come for another visit, if you click here the patient's name on the patient list, this one was test patient, you click that, you get the list of patients, and then you choose the one that you want to edit and add the data on. So once you add the follow-ups, this is what you eventually get when you go into the follow-up. So you start seeing them sequentially. So that's the first registration, that's your second follow-up. You can have a summary of all the behavior, and then those are your laboratory tests, which I added separately for you. Likewise, this is the conventional therapy, the steroid therapy, whether they had 5 ASAs, and there's where the enteral nutrition goes, and then that's your biologic treatment tab. Just to show the surgical side of it, patient didn't respond to, actually had a reaction to infliximab, so there's a safety element there. The persistent symptoms, had surgery. So we have to log on to the patient, we have to register a follow-up, we have to add that he didn't respond to conventional therapy, we had to add that he didn't respond to biologic therapy, and then that's what you get with all that. And then, what I'm missing here is you have to add the surgical treatment. Okay, so it's actually quite straightforward. So this is just how other people have used Eurocare for research. So the Belgian group are using Eurocare as part of their daily care. So that's within individual centers, and they collect both retrospective and prospective data to follow up the patients, to see the visualization, to calculate disease activities. But they also have a big research component to this. At a national level, there's the BIRD study group, and at international level, they've applied for studies, such as the Miracle studies, for other centers to participate and have their own little kind of project. So at a national level, they have a number of active sites, they sign an agreement, there's a contract to be signed, they need ethics approval for these studies, and each center is notified about the data and that the data will be used, once you've obviously approved that. And the data of the center will only be used after confirmation. So if you input data, nobody can use your data unless you actually confirm. And then similarly for the international data. And this is some of the data that you see once you're inputting your patients. You can see the diagnosis of the condition, the male-female ratio, for instance, and the type of biologics. And you can also delve in deeper, first-line, second-line, third-line biologics, as we saw earlier on. And this is what they've done in terms of integrating it with the biobank. So they have the Bird National Registry with 12 centers at the moment, and a few of them are also inputting samples into the biobank. And this is the Panther study, where people are collecting serum, stool, biopsies, DNA samples at different time points from those different centers. And so now you can see the wealth of potential from using the registry plus affiliating it to the biocenters, so biosamples. So I think that's pretty much it for me. So just another little exercise if you wanted to use it as a retrospective study. So for instance, we have several new drugs being marketed for inflammatory bowel disease. So if you wanted to conduct a retrospective study to assess effectiveness and safety of filgotinib, for instance, in ulcerative colitis, then the first thing you would do, obviously, is develop a protocol to include patients on your database who are going to receive filgotinib. You decide the follow-up. You choose your core outcome set domains, which in this case is medical therapy-related safety, and also disease activity. You decide on the primary outcome. I've chosen here a primary outcome from a tofacitinib study that was reported by the Dutch group, which was steroid-free remission. And then you can decide on secondary outcomes, such as biochemical remission, safety, and also discontinuation rate. And so this shows the core outcome sets for medical therapy and safety. So the medical therapy, these are the core outcome sets, and then your measures depend on disease activity, and then all the safety measures, these are sort of like all the outcomes related to safety, and the measures would be treatment discontinuation, number of hospital admissions, or medical therapy-related mortality. And here, just to show you the relationship between some of the disease activity outcomes listed here, which is clinical, endoscopic, or radiological, and this is how you measure them. So this is what the ECHO consensus group included also in the core outcome set. So you might opt for one of these, or a combination of. So for this particular study, once your UCare is going to act as your electronic clinical records form, so you're going to consent the patient for data inclusion. Once you know they're going to start tofacitinib, you'd add the patient demographics like we did together. You'd add the disease characteristics, a diagnosis, and also on subsequent follow-up, the different drug treatments, information on previous therapies and any biologic therapies, and then you go to your clinical activity with baseline lab tests. So you're here now, 12 and 24 months, you're still there, maybe adding different things depending on what happens to the patient. And then you can use the notes to identify that that patient is in your study, so that when you search your database, anybody where you have the note that the patient is in the study will be extracted. And then you just need to find collaborators to participate with you. So you've done the initial bit, and you can look for other centers and say, do you want to do the same thing as me? Collect your data from your patients, and then we can go back and retrospectively look at the data and find out what happens to patients being prescribed filgotinib. So sorry, that should be filgotinib, not tofacitinib. I just spotted that mistake. So that's the potential of UCare and the importance of the core outcome sets. So I hope I've shown you the diversity of outcomes, how it allows, how the core outcome sets allows homogenization of data, to collect data from different sources into a large data set, how we can embrace and interact all the databases into one universal database across Europe. And I think EuroCare still is a powerful platform for future collaborative studies and has the potential to have big data for across Europe. And, you know, we have a EuroCare committee, we have a EuroCare users group. So maybe for, you know, for Spain, once ENEDA data is incorporated on EuroCare, then it will be easier for you to use it and to adopt it, but you can still use it independently if you wanted to do some studies. So I think that's it from me. Sorry I kept you so long.
Thanks, Naila. I'm going to open a very short question and answer moment, because we have here the NADA database, so we know how it's easier or difficult to fill this information, this data into a database. So perhaps we could have a short discussion on how we feel is, for example, a NADA database to perform observational studies or to perform epidemiological studies. And we have one expert here who has managed all those data in the NADA, so vamos a abrir un pequeño debate muy cortito, ¿vale? Sobre cómo vemos.
So, as I said, we're going to open the floor for a debate about, well, the perspectives of these databases, whether we find them easy, not so easy. So let's talk a little bit about this.
Clinics, outpatient clinics, so it's very hard to be updated, all those databases at the moment the patient is in. So what do you think this would be the basic research group or basic research staff we should have to implement such kind of databases, for example?
So you mean to enter the data regularly?
Mm-hmm. Because it's difficult when you have a patient, so you could, when you could write yourself, apart of write the report, the electronic report, then you have to go to the database and enter the data they ask, so it's hard.
Yeah.
So so it's how do you manage to do that in instant maths, for example?
Okay, I understand the difficulties, and I think the value of a database is that you don't want to replicate work, you see. So you don't really want to put work into your records and then do a same separate thing, so you want to do it once. So you have a few options. So one option is to input the data straight onto the database, and then you generate a PDF report. Very easy, I showed you a copy of one. Yeah, and then you can put that in the patient's records, yeah? And you can add a note or two. You can actually even add it in the notes. So you can create a PDF document from EuroCare and put it into your clinical notes. Yeah. So that's one option. But it is really important that a patient's electronic health records are not interrupted, because patient care comes first. Another option is to have the database for designated clinics, if you like. But obviously, it depends on the way your health service works. So when we did it for the PAM study, where we looked at patient activation, we used it just in a new diagnosis clinic. And that new diagnosis clinic has half an hour set aside per patient, which is a luxury. But it's multidisciplinary. So there's a nurse, there's a doctor, and sometimes a pharmacist. Yeah, and so everyone does a little bit of it, and that's how we used to do it. We now have an increase in IBD pharmacists, and they do dedicated clinics. So they will do a TOFA clinic, they will do a biologics clinic monitoring, and again, they have more time in their clinics. So I think they have 20 to 30 minutes per patient. And so they will have time to input that data there and then generate the report for the patient records. But yet, I appreciate that time is an issue, but it's about changing the way you work. We input data all the time, okay? It's just we input it in an unstructured way. and all you're doing here is that you're structuring it.
Vale, una pregunta. Muchas veces participar.
Okay, I have one question. Frequently, when we participate in studies, we realize when we go and collect information that we are missing lots of information.
Data, we missed a lot of data because we don't are working systematically.
Yeah.
No trabajamos de forma sistemática. Entonces,
We don't work systematically. So me, for example, thanks to the EPICOM study,
he asked me to answer. So when I saw patients from the EPICOM study, I always followed that structure. But then I use that structure for everyday practice. Entonces, lo que hace cuando tú participas en un estudio es que
when you participate in a study, what happens is that you realize that you're collecting all of the data, you have the data, you start to work to collect them, and when you, well, without even noticing it, you're transferring them to another one, so to speak. You, in your hospitals, how do you do this? Do you use some templates or whatever when you write your reports or your clinical course, or is it a sort of mental plan when you write that? Do you force yourself to, for example, write in activity indexes or rates when you receive a patient? Is anyone willing to answer? Yes, I totally agree with you, Vicente. When you participate in a research study, you realize you're obliged to increase the quality of how you collect those data. We, for example, well, that depends on each of our clinical records and on the software we have. Ours allows us to save some sort of templates. We each have a different one, but we share many things, and you can have that sort of template with, for example, usual therapy, parameters that are going to be part of the index, complementary test, last lab test, whatever. Everything is blank, so I have to fill in those spaces. It's not nice seeing it blank. So it's like it's forcing me to review all those items and fill them in. So we have created our own templates to be able to do this systematically this way. Anyone else would like to take the floor and add something? See if somebody dares raise his hand. Who uses the heart data show or Mayer's index for all of their patients visiting you? No? Well, with the Harvey, what I'd say is that my feeling is that I sometimes have a Harvey 4 patient where I receive a remission, and there are patients with a higher Harvey who are active. So that Harvey score number for me is sort of useless in many cases. I rather say number of liquid positions, graduated abdominal pain, mild, severe, whatever, low, general condition plus abdominal, if there's an abscess. And then if I want to retrospectively analyze that, I have these data. But entering the index doesn't really help me much. And when we review data, and it's true what you said, we should all conduct retrospective studies, reviewing records and looking at what we're missing. For example, weight. Weight is really important. Weighing our patient and following that up, monitoring our patient's weight, that's really, really relevant. So, for example, analyzing if that's there. You're doing Bristol 6, 7 positions, and that, a patient that's operated, whatever. Okay, that patient, I don't know, a patient with a reservoir, for example, it's going to be 6 liquid positions, baseline minimum. A Crohn patient with obstructed pain, perhaps the previous day there was no occlusion, or 2 days before, you conduct a Harvey and it's 0, but for me that's a serious patient because you have repetitive occlusions with stricture, a risk of perforation, etc., etc. So for me, Harvey is, I do not really expect to see it as part of our histories, but I don't know. Well, the message is not so much adding a number than being able to show, to reflect all of the symptoms that are required to calculate a score, an index. Because, for example, if you want to take part in a European study, you're going to receive those numbers, you're going to need that. Because then what happens? You have a single center, or different kind of study where you are told severity was assessed by the doctor, and that's not been properly done because it's objective. Do you know what I mean? It's difficult sometimes. It's difficult to understand what the core outcome set is and what are the important ones there, and how do we measure them. We know that sometimes it's not enough, but the message I wanted to communicate here is, okay, there's a lot of work in what we do. We cannot fill in all of these data. Well, perhaps we have to, in our daily routine, start and consider these small ideas and see how we can structure, for example, first 4 or 5 questions we need to be able to later on collect all the information we're really going to need. And, well,
the splendid talk. I learned a lot of core outcome set. So just think of it when you're working every day. So it's much more that seeing patients and asking how they are, but also trying this information to help in the future to other patients.
we apologize from the interpreter's booth, but the microphone seems to be off. It's working now, okay. Okay, so this is the part, the debate, the discussion part. I like to see people closer instead of hiding behind a panel, a table. So there we go for it. This is a sort of two-sided part. We're going to have 3 different visions, 3 different views about the challenges for handling patients suffering from IBD. What are the future challenges? What are the doubts, the questions we currently have regarding the epidemiological aspects of inflammatory bowel disease? So, we're gonna listen to the perspective of a specialist, a physician caring for patients suffering from inflammatory bowel disease. We, as good epidemiologists, what she's going to do is she's going to launch questions at us in terms of the implications of talking about epidemiology. What are the implications for clinical practice? So that's one thing. Then we're going to sort of get out of our bubble where we all IBD physicians are, and we're going to move on to primary care. We know that many of our patients are very much in our consultation rooms, but we just think about those coming to us, and we tend to forget that there are other sort of care divisions, other care levels around us that we should resort to better. They should also resort to us better in a more cooperative manner, not in a vertical manner, but in a more horizontal manner, working in teams. So we have the view of a primary care doctor with us as well. And then doctors talk and talk about drugs, drug response, what's frequent, what's not frequent, how disease presentations and so on. But I do not know many doctors suffering from IBD. I think I know none, actually. I don't know, perhaps they're afraid or ashamed of saying so. So I think that the vision of how do you feel when you suffer the disease can only be given by a patient. And we're very lucky to have a representative from ACU with us here, a patients group. She's going to tell us what happens to her. What are the concerns she feels about when we talk about all of these epidemiological issues? So, first of all, let me introduce Maite Diz-Lois to you. She's a physician in A Coruña, it's the north of Galicia. She's responsible for the inflammatory bowel disease unit in A Coruña. She didn't know a lot about epidemiology, that's what she said to me. And I said, well, just pose any questions to us because you have to learn about what you do daily. So thank you for being with us, Maite. She's going to launch a set of questions to us. We have 3-4 slides. We're going to launch them all in a go. And when they're finished, we'll open up the floor for a general discussion so that you can all take the floor. Thank you very much, Vincent.
Yes, can you please show my slide? From my point of view, Vicente told me, well, ask some questions about the challenges related to epidemiological studies. After the findings of epidemiology, talk about the challenges ahead. So I'm going to talk about it from my point of view as a specialist in inflammatory disease, but we are also going to have a primary care physician and also a patient. I've got 3 slides with key points from my approach with regard to the disease prevalence, which is increasing. Maybe the incidence in some countries has stagnated, but I guess that prevalence has not reached the plane yet. So the number of patients is increasing. Also, the number of elderly patients with IBD is increasing. So I think there's a considerable challenge there for the health system as a whole, regardless of the country. Public health systems should think about hiring more resources and also increasing resources, increasing diagnoses in order to avoid colorectal cancer, for instance. So there's a considerable challenge there. And related to elderly patients, we also need to bear in mind their comorbidities. So we are going to require more assistance from our specialist doctors in elderly patients, also from primary care physicians, and we need to integrate all that information. What else can I say? Primary prevention. There are some ongoing studies with the purpose of looking for ways of preventing IBD. So why don't we try and stop that increasing curve instead of getting ready for the tsunami? But, well, we're still in the process of exploring that possibility of prevention. We also know that in relatives of patients with IBD, we know that although genetics is not the primary factor, we know that genetics also gives us some hints. So we could possibly identify possible risk groups and how would we do it, and then which risk factors can we modify. For instance, should they eat enteral purees in order not to suffer from inflammatory disease? Probably this is not the best idea, but maybe they should adopt a healthy diet. In that case, which diet are we talking about? For instance, we know that our patients are smoking even though they shouldn't. So it is difficult to impose a super healthy diet on the whole population. And maybe if this is not going to be efficient, what's the point in doing that? So, well, there are many questions to be explored and many open answers. And then, what else? Let me see. I had 3 slides, one more. Okay, so the next slide is also important. It talks about epidemiological studies and how they show an evolution of the disease, which generates a lot of disability with many hospitalization rates and surgery. So we need to talk about secondary and third line prevention. So we need to study very well the strategies that we are implementing. Are they efficient? Can we talk about treat to target? This is not feasible for every patient. So all of this needs to be researched by epidemiology. We need to understand what is the best way to measure the outcomes and whether the measures that we implement are actually having an impact on improving patients' quality of life. And at the same time, we need to take care of the assistance that we provide. Epidemiological studies also give us some hints about the quality of care that we give to our patients, and not just in the digestive ward, but across the whole hospital area. So it helps us to assess the quality of care in our hospital centers and to detect gaps, problems, so that we can improve patients' care and so as to avoid eventual complications. So that's why we need to also apply second line and third line prevention and allow our patients to remain in remission for longer periods of time so that they do not suffer from blockage or from strictures. And, well, we know that there will always be differences in different health scenarios, but, well, these are the challenges I wanted to show you. Hello? Thank you, Maite. I think there will be plenty of time to discuss many questions, which are, some of them are philosophical questions, but they're also very much down to earth. So from the point of view of primary care physicians, Dr. Benito Rodriguez comes from a health center here in Corucho, in Vigo. But he's been there for just 5 days. Before that, he was based in Covelo, which is a small town in the mountains, an hour and a half away from Vigo, deep in the mountains. It's a very rural area. So it's good to have the approach of a rural physician, because we really want to know what your approach is to that. Okay. Can we show the slides, please? My concerns, all sorts of concerns, because, you know, in primary care, we receive the first visits that are going to become chronic conditions later on. So it's important to see those patients at primary care. So I come from a very rural area in Galicia, and we have a very elderly population. Something like 60% of my population were over 65 years of age, and 20% were over 80 years of age. I have a patient who is 103. I have plenty of them from 95 to 103. So, of course, they have many comorbidities, they are polymedicated, they are extremely fragile, so it's very difficult to treat patients who are elderly and who have chronic IBD. Apart from that, many of them have high blood pressure, ischemic heart disease, chronic renal failure, diabetes. So now we have some new drugs that we are not so used to working with in primary care, such as anti-TNF, etc. So sometimes we are worried about using these new drugs that we are not used to prescribing. So on my slide, I have written that there should be a good coordination between primary care and IBD units. Coordination should allow us to be present in all of the stages of IBD so that we can provide first quality care to our patients. I mean, from early diagnosis throughout the whole course of the disease. We know that the earlier the diagnosis, the better the response to drug treatment is going to be, for instance. but sometimes we do not have enough tools like you all have. At primary care, we often lack resources, we lack algorithms, and we do not have specific tools which are directed to primary care physicians. We are not surgeons, we are... Oh my God, that's loud. So we need some perhaps simple data, because we have very little time that we can dedicate to each patient. So we need some simple data that will help us help that patient in particular, and before the patient suffers from a serious condition like ulcerative colitis, for instance. So let me find the slide. And so the evidence clearly shows that mutual trust between patient and doctor is very important for for both sides. I mean, both for the patients and for doctors who need ongoing training in order to learn more about IBD. So I think we need more specialized training. And the fact that we can visit hospitals and talk to specialists in order to understand much better the pathology that we see in our offices is going to have very good results. And at the same time, it is interesting for specialists to go to health centers in small towns and get to know the family physicians, so that we can have a better relationship and we can exchange more information between us. This is all going to be positive for our patients. So I have one question, actually. Since this coordination is going to enhance the outcome for all, I would like to know whether you are actually trying to coordinate the actions of primary care and IBD hospital units. Are you taking any actions along those lines? You know that primary care physicians are always ready to collaborate, but we need you to come and visit us so that we can reach a consensus. We often do not like to receive instructions directly from the hospital, because we have different work methodologies, but it's interesting to have some guidelines that we can use. So I would like to know if you are considering any possible actions, such as maybe implementing some procedures to better coordinate the work of primary care and specialist units. That is the second question, I think. And the next question would be the role of primary care in the follow-up of IBD patients. The role of primary care. I think we can do a very good follow-up of patients when, for instance, when they are in remission, provided the patient is not of high risk, provided they do not require a very high dosage of medication that could have refractory effects, etc. So when the patient is well controlled, when the patient is in remission, I think we can actually implement a good care for those patients. But we need more training. We do not have specific training. If 1% of the population has IBD, I actually do not see them. Certainly, young people will never come to us with IBD unless they have to go to the ER because of an abscess or a blockage or something like that. But they will never talk to us about IBD issues. I have never read that in the medical history of elderly patients either. And we know that the incidence of IBD is actually increasing in elderly patients. but I have not seen it in medical histories. And actually, in my clinic, 80% of my patients are elderly. They are receiving multiple meds. They have comorbidities. They are not in balance. So sometimes it's very hard for us to manage these patients and treat their IBD. We need support. We need more training. We also have issues which are not related to IBD. For instance, we can manage complications resulting from IBD. Also prevention measures, which is one of the key points of the primary care physician, which is prevention. For instance, helping people to quit smoking, monitoring the possibility of colorectal cancer, immunization. I think there is quite a low rate of patients with IBD who receive the proper immunization schedule. Correct me if I'm wrong, but I think this is the case. So we need to coordinate each other better so as to call those patients and try and update their immunization schedule. Because, you know, one of the problems that they suffer from because of their low or poor immunity is infections. Monitoring, I mean, this is the population that I worry more about because most of my patients are elderly. So what could we do? How can we contribute to better monitor the care of elderly patients? As I said, I come from the rural area. I had many patients who were in bed and they had multiple morbidities, ischemic cardiopathy, chronic renal failure, peripheral venous disorders, etc. So some of them were on 22 different meds daily. So of course they have IBD. And if you give them on top of that biological drugs, my legs start shaking because I'm really scared to give them new drugs. And, you know, not knowing is the same as being blind. And you just cannot prescribe the best medication for your patient. So we need more training. Once again, I'm asking for more training for primary care physicians. And also having direct contact with specialists if we need it. Sometimes we may need a dermatologist because I see a patient with a rash, you know, the extraintestinal manifestations of some IBD cases. So sometimes we need to call an eye doctor because uveitis. So I don't know how we could go about that in order to improve the quality of care. If there is a right procedure which is agreed between the specialist unit and primary care, this would be beneficial for all. You could learn from us, we could learn from you, and our patients would be better taken care of, and I would feel much happier and relaxed about it. Thank you, Benito. And finally, I'd like to introduce to you Raquel Vila, who is a patient, our patient. She's the social media coordinator of ACU. We have been trying to collaborate with them, with the association, for some years. We would like them to collaborate with us. We also attend their seminars, and I think that the ward has tried to foster a friendly and fluent relationship with them, trying to strike a balance between medical interest and patients' interests, but we would like to reach a consensus with them, with our patients. And so I invited her to come and ask some questions. And, well, she volunteered. And there she is. And, well, I'm curious to know what she's going to ask. Thank you. Just like Dr. Vicente has said, my name is Raquel Blanco. I'm the youth coordinator of the Association of Patients with Crohn's and UC, and I'm here representing the patients who suffer from these conditions. First of all, I'd like to thank the whole organization also for your research work, because you're trying to generate improvements in the diagnosis and treatment of IBD and other conditions. I'd like to also thank Dr. Vicente for having invited me. And I'm going to ask a few questions. I'm just going to fire a few questions that we have as patients. I have organized my questions in 4 blocks because some of them are interrelated. The first block of questions deals with the geographical differences and pediatric disease. The second block deals with protective factors and risk factors, such as smoking or oral contraceptives. The third block will talk about associations of patients, or rather associations with other inflammatory conditions which are immune-mediated. And the fourth block will talk about how to decrease the global incidence of intestinal inflammatory diseases. So, the first block, dealing with geographical differences and pediatric disease. My question was, what is the reason for the differences in IBD between developed and underdeveloped countries, and why has the incidence of Crohn's disease increased so much in pediatric age? In the second list of questions, talking about the risk factors and the predictive factors, the question is, why smoking has a different impact on Crohn's and on ulcerative colitis? The second question is, could oral contraceptives lead to the emergence of IBD? In the third block of questions, I would like to know why inflammatory diseases tend to present with other immune-facilitated conditions such as rheumatoid arthritis. And in the fourth block of questions, I wonder whether it would be possible to decrease the global incidence of IBD and how we could achieve that. That's all. Wow. Thank you. Just look how much we as doctors can learn from our patients. We are not aware, I mean, when we see a patient, we're actually not aware of what their concerns are and how many of her questions are not actually asked by doctors, and they are extremely important. So it's very important to actually listen to patients' concerns. And actually, we realize that they are not very different from the questions posed by the specialist in IBD or by the primary care doctor. So the things that we worry about are very similar, but we tend to prioritize one or the other. And so it's very useful to learn about different points of view related to IBD. So let's start about the incidence. Is IBD increasing? So you can just raise your hands and answer that question, if you please. We're going to talk first about pediatric. During the coffee break, Maria and I were discussing your first question. The increase in the incidence of IBD, should that lead us to hire more resources? Maria and I thought that it was too late, because when we do an endoscopy to a young child, you need to give them sedation. Maria does it at the intensive care unit, and I do it here at the hospital with the anesthesiologists. So you need to do more endoscopies, and we do not have enough anesthetists. So, you know, it's very hard to schedule endoscopies at the intensive care unit. There are many, many more planned than they have resources for. So the anesthetist told me, well, but if we have a very clear protocol for pediatric patients, you're going to ask me for more pediatric endoscopies. And I told her, of course not. Endoscopy is only performed in children when it is absolutely necessary, but we still need more endoscopies, more procedures for pediatric patients, and that's a problem that is there. So what do I do with the child when they are suffering from an IBD flare? Well, I need to admit them into hospital and practice all of the clinical tests that are necessary. And I have to fight from morning to evening with all of the specialists and all of the wards so that the child can undergo an endoscopy, if possible, without hospital admission, if possible, with ambulatory endoscopy. And it's very hard, you know, to coordinate all the resources. And Maria and I were just talking over coffee about exactly that question. So it is true that IBD is on the increase. It is true that it is also increasing in the pediatric population. And so we need to coordinate ourselves inside the hospital to coordinate the lab work with the diagnosis, etc.
The pediatric inflammatory disease is increasing. Do you have any theory or any idea about this? Or ¿tú también tienes alguna teoría de por qué? Porque muchas veces no tenemos.
Sometimes we do not have the answers, but we try to look for those answers. So why does it seem to be increasing in the pediatric population? I'm referring to pediatric IBD.
Yeah, I can. I mean, we have a pediatric. Okay, hold on. It's hard to get double translation. We have a pediatrician with us, so I think she's the expert in this. But, you know, it seemed that it's mainly linked to the environment, right? Our genetics don't change that fast in 40 years. And there have been studies showing that an increased use of antibiotic in childhood increased the risk of developing IBD as a child. And we've seen that also in adults. So something about the initial question was, is it the infection that require antibiotic that cause IBD, or is it the antibiotic? But it seemed that it's the antibiotic because antibiotics change the gut microbiome, the type of bacteria, virus, fungi that we have in our gut. And by changing this type of bacteria, we are decreasing the protective type of bacteria, the anti-inflammatory one, and promoting more the pro-inflammatory bacteria. So antibiotics seem to be playing a role. The second thing is there is the excessive hygiene hypothesis that we're too clean. So I don't know how it is in Spain, but in the US, it became an obsession that everybody was, you know, sanitizing, alcohol. You can't touch a baby without washing your hands 5 times, as if you're going to the operating room doing a cardiac surgery. If a baby falls on the floor, they get really cleaned up. And so that excessive hygiene is not stimulating our gut microbiome to recognize what is the bad bacteria, what is the good one, when to become tolerant, when to get inflamed, when to not. So when my kids were growing up, now they're teenagers, I have no control over them anymore. But when my kids were growing up, you know, if they were on the playground and they dropped their cookie, I'll be like, pick it up and eat it. Get some of those good germs in you. And the other mothers on the playground, they'd be like, you know, thinking I'm crazy. I'm like, no, I'm a gastroenterologist. I know what I'm talking about. So so we became too clean, and part of that too clean is that also our kids are having less exposure to nature, right? So growing up, we would play in the woods and come home at the end of the day and barely wash our hands and have dinner. Now our kids are sitting in front of video games, texting, going to living more in urban area. So that contact with dirt, with nature, we lost it. And that has been shown, actually, there is a study showing that kids that have a green playground in their neighborhood have less risk of developing IBD than kids who don't have that. So there's a lot of things in our environment that we don't think of as potentially triggering IBD, but they are, right? So, and that we need to address. It's very subtle. I think diet is playing a big role. Again, when we were growing up, we ate the same thing our parents ate. Now we do kids' meal that are junk, right? And then again, I don't know how it is in Spain, but in the United States, it's all fried chicken and burgers until you age 18, and then we tell you, you should eat salad now. And people are like, I don't like salad. I got used to eating junk my whole life. So a lot of our way of living is probably promoting that, because we see that there's an increased incidence in Western countries, but also now in countries that were developing. Once they have enough money to open a McDonald's and have burgers and have fast food, their risk of IBD is increasing. And we see that also in the United States in immigrants who come from countries where there's a low incidence of IBD. When they come to the US, within the first generation, their risk of developing IBD become the same as people who've been living in the US. And there was a very interesting study showing that people coming from the Philippines that were traditional farmers, so a lot of fruits and vegetables. They ate a lot of fruits and vegetables, and they were physically active, on their field. When they come to the U.S. and they're driving cars and no longer physically active, and they're eating U.S. food, within 3 months, their gut microbiome change already, and they lose the capacity to digest healthy vegetables, and they have more of the pro-inflammatory bacteria. So I think, talking about incidence and talking about prevention, it's, and knowing that diet and lifestyle not only affect IBD, but heart disease, cancer, everything else, it's becoming imperative that we educate the public, but also that we make these things accessible. We can tell everyone eat fruits and vegetables, but when they go to the grocery store and a lettuce is more expensive than a bag of potato chips and hot dog, then people are going to buy potato chips and hot dog. When healthy food takes time to be prepared and you have accessible, quick food, that's also a choice. And then I think one of the big disservice we're doing is that there's no control on what we label as healthy food. Cereals, the breakfast cereals, the cornflakes are labeled as healthy for your heart. They're actually ultra-processed food, very unhealthy. The protein bars, healthy food on the go, they're full of sugar and preservative and emulsifier, and all these things are affecting how our gut bacteria and our gut health is. So I think it's part of the government or the organization taking care of our health to really not allow companies to advertise their food as being healthy when it's actually not. And so there's a lot of things that we need to do in terms of intervention.
One question about pediatrician IBD, and it's, for example, you said that, perdón, voy a decirte en español,
when you breastfeed your baby, you spoke about that being a protective factor against IBD, or a cesarean could be a risk factor for IBD. So from your viewpoint as pediatricians, do you think that there's always been this going to and from breastfeeding and artificial feeding, favoring natural births or cesarean births, or well, first of all, natural birth and breastfeeding for many reasons, but because of this as well. And let me explain why. It's not perhaps so determinant in terms of developing IBD, but it's true that most of the studies agree on the fact that breastfeeding is a protective factor. Then going past the parturition channel and being born that way naturally is also of benefit in many cases. And so that's basically what many studies say, breastfeeding as that in terms of the immune protection it offers during those 6 first months of life, at least, that's undeniable. So 100%, if possible, natural birth and breastfeeding. So that's one thing, that's true, 100%. But there are other issues, as you were mentioning, that also play a relevant role, as you were mentioning, such as diet and so on. And that's shown by studies, and we see it in daily practice as well. Let me give you a couple of examples. As for diet, I think that 80% of the pathologies we see in our children's digestive rooms, if diets were healthy, we would not be seeing them. It impacts inflammatory bowel disease, but many other diseases. And also, inflammatory bowel disease, now that we're using these partial and enteral nutrition for, well, to treat outbreaks and to treat Crohn's disease. Now that we're doing that, we're learning many things. We know and we knew that exclusively enteral nutrition could be effective to treat an outbreak. We were afraid of using partial nutrition because we used to think, how am I going to control this? What are families going to do about this? But what we're seeing in daily practice is that it is as effective as enteral nutrition in most cases. And when patients start to eat worse, we typically see a new outbreak. If I move a step backwards and go to a previous stage on my diet, then the patient enters remission. So diet clearly has an impact on pediatric inflammatory bowel disease. And on many other diseases and at other levels. And then, as for antibiotics, well, the world and the history of health has brought us to a very peculiar point in time, that of the pandemic. In the past 3 years, we've had our children sort of overly protected. They haven't gone to school for a while, they've used face masks, always washed their hands, and now they've removed their masks and they go to school always. So we've had these 3 years where we didn't have many patients. We've had no viral diseases in patients, so less infections, lower use of antibiotics, and that's something very, very peculiar of these past 3 years. But now, since this autumn, we are having a boom in infections, viral diseases that we had never seen before. Pediatric rooms are full in our hospital, lots of admissions with co-infections we hadn't seen before, VRS, influenza, many different viruses circulating at the same time. And that's leading us to using many more antibiotics. That's even worse and worse. So it's a nightmare. And if we compare globally what's happened during these pandemic years with inflammatory bowel disease and what's going to happen now with what we're living now, there's an increase in the use of antibiotics, clearly. If we compare that, perhaps that would help us cast some light in terms of well, the influence of infections and antibiotics use on inflammatory bowel disease. I think it's interesting to analyze. Let's move on to another block of questions. We were talking about risk factors, and somebody mentioned smoking. Raquel was asking about how smoking can be some sort of dual. I mean, I don't know if you want to answer, Diego. I know it's difficult, but it's even harder for us. I think that with IBD, the same as for lung cancer, smoking, that then everybody's clear about this. And the first epidemiological studies were conducted and based on that, so it's clear for that. But here, there are so many factors. We talk about diet, microbiota, smoking, and we analyze them one by one in every study. Let's look at what happens with antibiotics here, with smoking over here, separately. And we do that, and frequently we forget that factors interact amongst themselves. It's a network. It's not a straight line. It's just a network, as I said, full mesh. And there are parts of that network that are really dark. We don't know what's behind them. And, well, I don't know the answer to what you've asked, the same as I don't know many other answers. But what I do know is that in the end, very frequently we talk of diseases that we bring together under the same scope: intestinal disease, bowel disease, but frequently, I don't know, ulcerative colitis, for example, it may resemble more other diseases than a Crohn's disease in some regards. So I think that we have lots of dark or shadowy spaces. About oral contraceptives, I'm going to launch the question at myself because it was included in the part about women. It's a risk factor, yes. Why this is so, it's not clear yet. Obviously, we are giving more hormones to women, and that may be having an impact in terms of, its influence. Probably there are mechanisms there that I think that a pathway for research is being sort of opened up and newly explored. We know that we have many social movements pushing forward, trying to empower women, trying to make the role of women more relevant, trying to pay more attention to what happens specifically to women. So I think that in a few years, we will probably have more responses to answer these questions, but we don't know for sure yet why this is so.
One more thing is it's true that the data on oral contraceptive with high estrogen have been associated with a higher risk of IBD, but the one with the newer one, low estrogen, don't seem to increase the risk. But in women with IBD, it's important to remember that the reason to avoid estrogen containing is not just because of the risk, but also estrogen increases the clotting in women, the clotting from birth control pill. And we know that IBD, when women with IBD have highly active disease, it's also increased the risk of clotting. So just for my patients who want to be on a birth control pill, I typically recommend that they use a progesterone-only pill without the estrogen, or a non-hormonal method of contraception, like a copper IUD or something like that, because of this hypercoagulable state and because of the potential of the estrogen maybe increasing the risk of IBD, but on a lower dose probably not, but it's something better to avoid.
Mm-hmm. And then we will move to the challenge. Vamos a pasar a los retos.
Let's move on to the challenges put forward by the health organizations, by Maite and Benito, the physician representatives. So,
the interaction between primary care and IBD units in the UK.
Yeah, so it's very country dependent, very organization dependent. And, I can hear your frustrations, but equally, I also hear how busy you are in secondary care. So I think the basic problem is time, isn't it? Mm-hmm. So I guess it's about having a process and a pathway, about maybe having scenarios that GPs can manage and be trained to treat independently, such as when somebody is in remission, having a regular review and what to do with the regular reviews. Then having specific conditions where you can't really manage the patient, because even we find it difficult to manage. And obviously, Elena will tell you about all the complex cases that she discusses on her Twitter feed. So it's about knowing the skills mix that's required and trying to fill the gap with some other healthcare professionals, because IBD is now multidisciplinary. You have dietitians, you have IBD pharmacists, you have the amazing IBD nurses, and trying to find a role for those different healthcare professionals. So the way we've dealt with it is, we have a very good nursing support. I have 11 IBD nurses in our unit. I created a new post, which was a lot of work, and, trying to get money out of the National Health Service. It's like, squeezing blood out of stone. So we managed to create a post, which was called an advanced nurse practitioner, to work out in the community. So GPs that have problems will use her to, as a communicator, if you like, with the rest of the team. So her job was to interact with GPs. So she had a mobile phone, they could call her. She would follow up the patients, the ones that are difficult, she would obviously discuss with us. But I also think that in this modern era of information technologies, and I think COVID has really helped in this regard, because we have had to embrace more healthcare portals. We were forced to with COVID. I'm sure there must be some sort of platform that you can use to facilitate the interaction, and I'm not sure whether that's being examined. We are at the moment going through a research priorities partnership, setting partnership. I try to identify what digital technologies patients want to help them to manage IBD, and maybe that will eventually lead to a list of questions, and then research can be focused on those. And I remember seeing one of the questions being the interaction between my doctor when I see him, who doesn't know what the doctor in the hospital is saying about my condition. So having that kind of more holistic care. But you know, the interaction between primary care and secondary care has always been challenging. You just have to find something that works for you, and we've found this thing that works for us.
But I think that kind of nurse,
advanced nurse practitioner and IBD, we call her. Yeah.
That it's the next, the union between.
Yes, it's the link.
Levels,
it's the chain. It's a chain.
Esa enfermería de nexo podría ser un papel interesante para siempre aprendemos cosas.
It's really interesting that, I mean, we always learn things when we listen to others, undoubtedly, so that link in the chain could be really interesting. Any other questions from, for example, there are representatives from different hospitals in Galicia and in Spain here. So, I don't know, still within primary care, any ideas, any program you're implementing in other hospitals, any kind of work with primary care, anything interesting you can suggest? We were talking about this in a meeting we had with primary care physicians a couple of days ago, and somebody said something, it was Nacho, our boss, he said, we have those patients with IBD kidnapped. And that 1%, I don't see it. So sometimes we think that we know a lot about inflammatory bowel disease, but we are not able to handle so many things ahead of us. So outside Vigo, outside Galicia, well, or in any other parts of Galicia, is there anything else you could add? Well, let me tell you about the experience we have in Asturias, just around the corner. What you have said is real. I mean, when we started our IBD units, the idea was to capture as all of the IBD patients we had diagnosed, and newly diagnosed ones as well. And that, well, it seems we've achieved it, but we're going to die of success because we have so many patients with IBD that we all know that we're not able to care for them the way we should be caring and we would like to be caring for them. I think that IBD units, we'll probably all agree on that, what they provide value to is complex patients, particularly, and newly diagnosed patients, when we have to sort of start the process with those patients. Then we all know we have groups of patients to which we don't add a lot of healthcare value. The problem we now have in primary care is that, well, we all know its situation in Spain now. Lots of deficits and lacks of staff, overloaded with work. And what we cannot do now is go to them and say, okay, we're going to give you these patients so that you are also in charge of them. That would be really, really selfish on us. We have to handle this otherwise. So in the short term, we have to focus our units more on complex and newly diagnosed patients and then coordinate ourselves with primary care with many groups of patients. And then there's something else, which is the role played by the nursery staff. In Spain, it took us a long time to have nurses specialized on IBD. We now have some, but they're not enough. We just have a very reduced group. In the United Kingdom, that's been better solved. The role of nurses in handling many chronic diseases is better over there than over here. And so what I think is that specialized nursing should increase and be more used for handling our patients. And obviously, it could be a link to primary care and to handling those patients at that level.
And then the thing we haven't quite mentioned is the patients involved in their care. So we spend a lot of time with self-management. Yeah. So we have educational courses, we have patient open days, and in our new diagnosis clinic, we spend half an hour educating the patient, giving them, we've developed a flare card, so when they flare, they know what to do. You know, and I think it does reduce the burden on the healthcare system, and it also gives patients confidence to manage their own disease. So patients can also help themselves.
Vale, voy a lanzar una pregunta y voy a aprovechar.
Okay, let me launch a question. And because we have Raquel with us here as a patient, I would like to pose this question specifically for her. So you're here and you're listening to us saying, look, digestive doctors don't want to be in charge of us. They want primary physicians to be in charge of us. How would you feel as a patient if we come and say, from now on, you will be, or you will have your primary care doctor in charge of your disease? It's a difficult question, I know. This is not what I heard from you. No, I know it's not exactly what I said, but we're talking about organizational issues. So imagine, no, if we say that. I've never heard that, actually, and I prefer a digestive doctor specialized in IBD, but I want that link between all of them as well. I don't know, I live in a small village, so if I have to go to my health center, okay, it's fine if we have a primary care doctor, but I want him or her to be in communication with a specialist. Great. The message I wanted to communicate here was that I think it's important, if we're going to make that sort of transition from, I mean, trying to offer a more sort of featuring role, no, to patients who are at, I don't know, have the capacity to control, and so it cannot be like leaping into thin air. I mean, the idea is that everyone in your healthcare area should be aware of all this, particularly patient associations. We're talking about chronic diseases with many aspects playing a role, and breaking, I mean, we could be breaking with our patients' confidence, so to speak. So if we're going to do something, it has to be coordinated with all the departments and units. And if we do it that way, it will be broadly and well accepted. If it's like a secret, we're going to do this in a hidden way, no one is going to know, that may create sort of discomfort. As they were saying here, I mean, we don't want anything imposed on us. So we need to try and go for that. And this brings me to what you were saying about accreditation, certification, quality of care, and so on. We have complex patients. We know that they have many problems that have to do with, I don't know, medical, psychological, nutrition problems. So how do we involve all of the stakeholders we require for organizing our departments? That's the key question.
First of all, thank you for being here, and I know it takes a lot of courage to talk to a lot of doctors. I get stressed out when I'm talking to a lot of patients, so anytime you're in a place that's not comfortable, so congratulations on being here. For us in the US, the gastroenterologist taking care of the patient with IBD becomes like the primary care, because there's a trust that gets established. And I think it's important to realize that as physicians specialize in IBD, we know the data more than, you know, the OBGYN, the primary care, et cetera. So we can't just say, primary care, you figure out the vaccination, you know, when the patient is on a biologic, that's going to be stress on them. So it's important for us to give guidance because we know the data. Or OBGYN, you know, you figure out if you're going to keep your patient on infliximab during the pregnancy, we give them that guidance, right? So, but it's very important to coordinate with everybody else. So in our practice, we really go over everything with our patients, you know, nutrition, their psychological health, emotional health, what they need to get as vaccines. So that part of the education makes it, like Nela was saying, that the patient is proactive in their disease. So they are advocating for themselves, they also know. The other thing that we do is, you know, we send all our visit note to everyone, the primary care, the OBGYN, anybody involved in the care, and we ask those notes also so that we are actually educating each other, right? So I send a note saying why the patient needs these vaccines, because they're on immunosuppression, not to avoid them because they're on immunosuppression. So that creates education with the primary care physician, so they're more and more comfortable giving those vaccines. Same with the OBGYN, who maybe see 1 or 2 patients with IBD their whole life, and I'm telling them it's okay to keep infliximab during pregnancy and breastfeeding. It's all part of that cross-education. Obviously, face event, like, and I congratulate you, Vincent, for doing this and incorporating primary care, because we're all living in silos, right? We go to GI conferences, primary care, go to primary care conferences, and there's no crosstalk, and I think that's important. But what we also have is a nurse coordinator. So we have a nurse coordinator, a nurse practitioner, because we also don't want the burden to get on the patient. You know, you're living already with an inflammatory bowel disease, you have to think about the treatment, everything else, and making those different appointments become also a burden. Your appointment for colonoscopy, CT scan, seeing the primary, seeing the dermatologist, etc. So our nurse coordinator facilitated that. So she is taking that burden out of the patient and make those appointments for the patient to try to relieve some of the burden from the primary care, from the patient doing all this. So I think the idea is to really work as a team where everybody is valuable in what they're doing, and when things are balanced. I think, like you said, it's not fair to tell primary care, just follow that patient on infliximab and call us if there's a problem. But also we need primary care in terms of health maintenance, vaccination, following up, letting us know if the labs are abnormal. We also need the patient to be proactive, and the more the patient understand the disease and what the treatment is and what kind of follow-up is needed, the more everybody's working as a team, and the burden is not on one person, but it's like distributed to the degree that every person can handle, right?
Okay. Para acabar, os voy a dar la oportunidad.
And just to finish, I'd like to give you the opportunity to ask, there are some questions from the social media. One, for example, if we look at IBD, or in between them and their units and primary care units, we have some other units where IBD specialists act as consultants for other digestive physicians. What do you think of this? Do you also have this strategy of sort of second level being sort of consultants or advice providers for digestive tract specialists that are not specialized in IBD? Do you have this experience? Very recently, I was working in a small hospital in Aragon, in a district in Aragon. I had been trained in a tertiary hospital before with an inflammatory unit, advanced practice, and so on. And well, Benito said before, I don't see those patients. What happens? How do they teletransport themselves from their home to the hospital without going past primary care? And it's true, we have a direct contact telephone in many units. We have email systems that are reviewed by doctors or nurses. So sometimes there's a sort of direct access. And very frequently, sometimes it's the primary care physician that's the first link of the chain. The patient is not feeling well, goes to primary care, receives more direct action, and then everything is activated. In some other cases, that step is avoided, so to speak. When you go to a small hospital where you have 2 or 3 physicians, there's no nurse, obviously. In these small hospitals, that role, in our case, went back to primary care physicians. And over there, I did have my sort of reference in my tertiary hospital. Complex patient, this kind of patient who's going to require any kind of surgery that is not going to be done in a small hospital. We have to refer her to a bigger hospital, MRI, imaging, some of the kind of issues, I cannot do them in small hospitals, so I have to contact a tertiary hospital, so that it depends very much. Perhaps not so much in those departments where an inflammatory disease is already included, because when we detect a patient is reconducted to that unit, but we do have that reference in those small hospitals where that doesn't exist. Okay, thank you. Any other question from the audience? No? I have no more questions myself. I don't know if... No, I think we're going to leave it here, yes. If you want to join me here, might as well, please, just to say some final words.
Sí, yo no.
¿Está apagado?
Ahora. Bueno.
So briefly, we changed protocol. Instead of being up there, we're going to remain over here, standing up, to close this conference. So nothing else. Thank you very much to all of you coming to the conference, all of the speakers, Mercedes, Benito, Laila, Vincent, Diego, Aline, Raquel and Maite, thank you very, very much. And to you all as well, the audience, those coming from other parts of Galicia or anywhere else. All of the members of the digestive team I'd like to thank you as well, because when a colleague organizes this and you come and join us, it's really, really important to us. And, well, it encourages us to do more things. And, well, nothing else. We'll start working tomorrow to keep on doing more things in the next few years. And I'm just going to give the floor to Vincent to say a final few words. And he was the organizer, and that's all. Thank you. Thank you very much for joining us, for participating with us in this talk, in this symposium. I'd like to thank those of you who have been at home as well. I was able to have a look at my second phone, and I've seen that there were many, many comments through the social media. I feel sort of, well, it's astonishing to, and really, really nice to see the nice remarks made by many of you. You also look very happy, and I am very happy for having you here with me today and always. Every year we receive you over and over again, and I'd like to invite you to be here with us in the next few years and share these moments with us. So thank you very much for joining us.
Ya nos podemos ir.
Time to go home. Thank you.